So good evening and welcome everyone to our pre-election town hall on major health concerns for Ontarians. Bonsoir et bienvenue à notre forum public préélectoral sur les principales préoccupations en matière de santé pour les Ontariens et les Ontariennes. My name is Ron Roseness. I'm a community health advocate and a consultant, and I am your moderator for this evening. So I'm happy to see everyone here, and I'm also happy to welcome people who are joining us via live streaming. I'd like to begin by recognizing the partner organizations who are hosting us this evening, including, you'll see this on the rotating slides, including the Save Your Skin Foundation, Myeloma Canada, and Canadians for Equitable Access to Depression Medication, CADM, in partnership with Lymphoma Canada, Connected, which stands for the Collective Oncology Network for Exchange, Cancer Care Innovation, Treatment Access, and Education, and finally, Lung Cancer Canada. So a few housekeeping words. Our town hall is meant to unfold quite informally. We want you to take breaks as you see fit because we're not actually planning any breaks over the course of the next 3 hours. Bathrooms are just outside the room. You'll see signs quite readily, I think. Refreshments, as you have probably discovered, are also available just outside the door at that end. So take breaks as you see fit, and please help yourself to refreshments. The agenda for the evening is also going to go by on a slide, but let me just tell you briefly what we have planned for you so you'll know that there's going to be ample opportunity for people to ask questions, both those people who are in the room tonight who can ask live questions and people who are joining us by live streaming, and I'll explain all of that in a moment. But we have no handouts tonight other than some literature on behalf of some of our hosting organizations. So in terms of the agenda, we're going to begin with a keynote from Andre Picard with some questions and answers following Andre's brief presentation. Then we're going to hear from people with lived experience. And again, an opportunity for you to ask questions. We'll hear from a health policy address from Louise Binder and a mental health policy address from Phil Upshaw. We'll again have time for questions before we hear from our guests from two of the political parties, the NDP, Frangelina is with us tonight, and Bill Walker, is he with us yet? He'll be joining us from the PC party. Again, there'll be time for questions, and at the end we'll have time for more questions again. But let me explain the routine here, because we want everybody to have an equal opportunity to ask their questions, to have a good kind of interactive discussion, with some provisos, which I'll also get to. But for people in the room, we will have a roving mic. You'll be able to put up your hand at the appropriate time and ask questions. I'll be asking all speakers to stay on track with their time, and I will also ask all people asking questions to be concise. There is information on one of the slides for people who are either prefer to ask a written question or are joining us by live streaming. For people joining us via live streaming, or anyone else who enjoys using the latest in technology, you can go to the website that you'll see on the slide, slido.com. Slido. And yeah, it's not the latest kid's toy, apparently. You can click on the website, submit a code, which is 9336. We'll make sure that you have that code. And then all you have to do is click on Ask a Question. And the lovely Martine will be collating any questions that are submitted using slido.com. She'll also be keeping an eye out for people in the room who want to ask questions here using the mic. Please specify if you wish your question to be answered by a specific speaker. And if you're really daunted, either by speaking publicly or by the use of technology, out the door to my right is a table. There are cards and pens. feel free also, if you prefer, to write your question. That way, you can also remain anonymous. Nous vous invitons à poser vos questions en français, si ça vous convient, soit ici dans la salle, ou bien sur le site web, Slido, ou écrite si vous préférez. Please remember, though, we are hearing from various representatives of political parties tonight, that this is not a political debate. This really is meant to be an informal and non-partisan event. So we asked our speakers to focus on issues, or problems, or challenges in healthcare that are systemic in nature. And we would ask the same of you who are posing questions in the room tonight, so that even if you have a personal story to tell, we would ask that you keep it short and that it be indicative of a larger systemic issue. And it's a systemic issue that could lead to policy change, because at the end of the day, we want to gather opinions in the room about what matters to Ontarians in terms of current health policy and what you would like to see policy-wise in the healthcare system going forward. So on that note, I want to mention just quickly that we may not have time to answer all your questions this evening. There are a few minutes in which we can stay after the town hall tonight, and we'll just make sure we stay within the maximum 3 hours for our presentations and questions. If anybody remains afterwards who didn't get a question answered, there may be a few more minutes. Unfortunately, though, we have to vacate the building by 9:30. All right? So unless there are any questions on the housekeeping, I'd really like to begin by introducing our keynote presentation from André Picard, who, as I'm sure you know, is a health reporter and columnist at the Globe and Mail, and an author who's been honored for his dedication to improving healthcare. André?
Thanks, Ron. That's very kind. Keynote is a big word. This is going to be a very informal presentation, as he said. What I want to do is give you some context for the discussion that's going to come. You know, it's budget day today. There's a provincial election coming up, so political discussions are really heating up. And there are very few things that are more political in Canada than healthcare, and healthcare funding in particular. So you're going to hear a lot of these points of view from patient advocates, politicians, consumers, and you're going to hear a lot of rhetoric and a lot of contradictory claims. So I want to try and give you some ammunition to figure out if this stuff is true or not, some context. So I'm going to give you a little bit of background on how the health system functions, how we spend our money, and some of the challenges that policymakers and politicians face when they try to make smart healthcare choices. I think it's really important to do this stuff for a couple of reasons. Number one, it's surprising how little as Canadians we actually know about our system. We don't tend to pay attention to healthcare until we're sick, and then we don't care about the system, we care about getting care. So we need to know that background, and some of these basic facts, if nothing else, I think will allow you to call BS on some of the things you hear tonight, and some of the things you'll hear on the campaign trail. So don't be afraid to do that. That makes for a more lively discussion. So as Ron said, I'm going to speak really briefly, and then I'll take questions until he cuts me off. So now I've been writing about healthcare in Canada for a little more than 30 years now. So in that time, I've accumulated a shocking amount of trivia and a little bit of knowledge. And some of that knowledge I think might be useful to our discussions tonight. So I want to start by talking about the system. We don't have a health system in Canada. We have 15 health systems that are very loosely connected. There are 10 provinces, 3 territories. That's the geography for tonight. There's a federal system, and there's a workers' compensation system that's separate. So that's 15. Now, the provinces are responsible for the delivery of care under our Constitution, for better or worse. Now, the only exceptions are for Indigenous peoples, the armed forces, veterans, the RCMP, prisoners, and refugees. All of them are a federal responsibility. So we forget that there is a Canadian federal health system. It's actually the 5th largest health system in the country. Now, Medicare. Medicare is a word that doesn't appear in any legislation, but it's the word that we give, the name we give our public health insurance system, and it has a different name in every province. In Ontario, it's called OHIP, the Ontario Health Insurance Program. It's an insurance program. It covers only two things: hospital costs, physician costs. This goes back to the legislation that was created in the 1950s and 60s. Now, the underlying philosophy is quite straightforward of Medicare. No one should be denied medically necessary care because they can't afford it. Now, those words medically necessary are really important and very ill-defined. Technically, what they mean in the legislation is hospital and physician services. So technically, only those two items are covered 100% by public insurance. But over the years, we've had all kinds of add-ons, informal and formal, across the provinces. So today in Canada, about 42% of drug costs are covered publicly, even though it's not technically under Medicare. About half of home care costs are covered. About 1/3 of long-term care is paid out of the public treasury, and about 5% of dental care and various things, eye exams, hearing tests can or cannot be covered. It's kind of a mess of what's covered or not. It's quite confusing, and you learn that when you're thrust into the system or when you are caring for someone in your family and you have to figure this stuff out. And it can be very costly out of pocket. Now, the Canadian approach is technically the academics call it a bifurcated system. So it's two sections, one that's 100% covered, and then another that's just, we don't know how much is covered. It depends. Every other Western country is very different. They tend to, almost every European country covers about 80%, 80 to 85% of all health costs, everything from dental care right through to physicians, and then it has to be topped up. And it's almost always topped up by private insurance. The notion of out-of-pocket costs, which we have a lot of in Canada, is virtually unheard of in other countries. So last year in Canada, we spent $242 billion with a B on healthcare. That's about 10.3% of our GDP. So about $1 in every $9 in the economy goes to health. There's about 1.1 million healthcare workers in Canada. It's a real economic driver, very important to our economy. 70% of our health spending is public. That's $170 billion in healthcare expenses are paid through taxation, federal and provincial. Ottawa transfers money to the provinces. Last year, they transferred $38 billion, or 21% of total spending. So when Medicare began, Ottawa had a deal with the provinces that they would cover 50% of costs. Over time, that's been whittled down. It's now just over 21%. We're a big private spender in Canada. 30% of our health spending is private. As I mentioned, that's much higher than any European country, where it's 15, sometimes 10% private spending. So we're very high. The only country that's higher, of course, is the US. And even there, their private spending is 54%. Had Obamacare been fully implemented, they would spend more than half their health dollars publicly. They would become a socialist country like us. Now, Mr. Trump has taken care of that. He's kind of gutted Obamacare, but they're very close to. And surprisingly, the US actually spends more on public health care per capita than Canada does. So we have a lot of mythology about our country being generous and being socialist, and they spend a lot on public health care. And their public health care programs where they exist are actually much more generous than Canada. Ironically, US Medicare, much more generous than Canadian Medicare, believe it or not. Now, we'll leave the 38 million people with no insurance aside for this discussion. And that's all I'll say about the US, because they're an outlier. We shouldn't compare ourselves to them. We should compare ourselves to other countries like France, the UK, the Netherlands, etc. What else do I want to say? Now, what should you take from this mess of numbers that I've given you? I think you should take a couple of things. One is this notion that health spending is out of control and gobbling up too many of our health dollars, our tax dollars. I don't think that really holds up to international scrutiny. There was a study out just 2 weeks ago, a big international study that showed that among Western countries, Canada spends actually the least on public dollars on healthcare. We're a very, very low spender. Even in overall health spending, we're just a little below middle of the pack. So we're not spending crazily compared to other countries. So So I think we should put that discussion aside. Secondly, and this one people don't like to hear when I say it publicly, but I think it's important to recognize that Canada has the least universal healthcare system in the world. So we cover a lot less than any other country, again, the US aside, except for their public programs. The notion that we're this generous, all-public system is really a myth. We were in the 1950s, we're not in the 2010s. Now, I just told you that health spending is not out of control, but that doesn't necessarily mean we should spend more. Those things are not, one doesn't necessarily follow from the other. It doesn't mean that current spending isn't a fiscal challenge, because it is. Ontario will spend $56 billion on healthcare from the public treasury this year. Again, that's 42% of the budget. By far the largest line item in the budget of every province is healthcare, followed by education, followed by infrastructure, and in Ontario, followed by debt payments. $12 billion in debt payments, the budget told us today. Now, during the 15 years the Liberals have been in power, and these aren't partisan comments, this is just factual information. During the 15 years they've been in power, the health budget has nearly doubled. It's gone from $29 billion to $56 billion. So again, we can't say that spending is not increasing. It increases relentlessly. But for the past decade, the increases have barely kept pace with inflation and population growth, never mind the growing demands of an aging population or new technologies. So you can argue whether spending is enough, but those are the factual background to that. Now, you're going to hear people tonight and on the campaign trail say that the health system is unsustainable. Now, I hope you'll be very skeptical of that rhetorical phrase. It's one of the things I hate hearing the most, because it's meaningless. First of all, you have to define what you mean by unsustainable. Do you mean unaffordable? Do you mean unfair? Do you mean not providing enough bang for the buck? When you say unsustainable, define what it means, or better yet, don't use that word. It's meaningless. For me, our health system is as sustainable as we want it to be. The question is, do we want to sustain the status quo, which isn't working too well, or do we want to improve the system? How we shape and fund our health system, or systems, are political and policy choices, and we should make them openly. So again, tonight you're going to hear from people who say that we're failing to provide a lot of things, that we don't have adequate drug coverage, we don't have sufficient mental health services, we need more hospital beds, we don't have enough long-term care, not enough doctors and nurses, and so on and so forth. Everyone says this in every country. Don't get too worked up about it. Now, is it worse here than other countries? In some cases, yes, in some, no. We'll see. Now, many of these demands are quite legitimate. They're true. But when you hear them, I want you to ask yourself three basic questions. Do we really need more of the same? When something isn't working, should we do more of it, or should we do things differently? We don't ask that question enough. In Canada, we tend to throw money at problems rather than innovate. And we're a wealthy country. We've gotten away with it for a long time. Number two, if we're going to spend money on problem X, whatever someone identifies, where's the money going to come from? Money doesn't grow on trees. It comes from taxpayers' pockets. There are trade-offs. If you want to spend more on health, you have to take it from elsewhere, education or roads, or you have to raise taxes. Those are the two choices. We have to be more upfront about that reality of where the money comes from. Third, what is the value of a new drug or service? We tend to talk a lot about cost, but we don't talk enough about value. A $100,000 drug can sometimes provide more value than a $5,000 drug. Those are different discussions and a very important distinction. And finally, how do we say no? Medicare is not supposed to be open-ended. We can't cover every health service for every person all the time. That's a reality. But how do we draw the lines? To me, that's one of the most pressing health policy issues in Canada today. So I'm going to stop there. I had one more issue. I was going to talk a little bit more about drugs, but I'll wait for later if there's questions. Do you want me to do it again? Okay, it's just 2 more minutes, but so let me just, yeah, there you go. We love drugs. There, rallying cry for the evening. And I won't even talk about cannabis tonight, one of my favorite topics. So Pharmacare. Pharmacare is a big topic. So let me say 2 minutes worth on drug coverage. In Canada, our coverage of prescription drugs is really a dog's breakfast. It's a patchwork of private and public insurance programs that's often illogical. One of the most striking examples is cancer drugs. In many provinces, a cancer drug is covered if you're in the hospital. The same drug is not covered if you're taking it at home. It's irrational. Again, this doesn't exist anywhere else in the world. Most Canadians actually have private drug benefits. As I said before, only 42% of drugs are publicly covered. So most people depend on their employers. Now, the way the work world is changing, fewer and fewer people have drug benefits. That's a reality. More part-time work, more self-employment. We don't have a single pharmacare program in Canada. We talk a lot about it, but we actually have 102 public drug insurance programs. So again, a real mishmash all over the place for specific drugs, specific ages, et cetera, et cetera. Now, despite all these programs, there are about 700,000 Canadians with no drug coverage. And there's an estimated 3.6 million with inadequate coverage, meaning they pay a lot of money out of pocket. These numbers are from the Parliamentary Budget Officer. To me, this undermines the very philosophy of Medicare that no one should be denied essential care because they can't afford it. So this is a really pressing issue to resolve, and it's not going to be resolved simply. Now, Ontario has been one of the most aggressive provinces on pharmacare, to its credit. It has an Ontario drug benefits plan, a Trillium drug plan, which helps people who can't afford their drugs. And recently, the government has extended coverage to those under the age of 25, which I've said publicly, the group that least needs it, but that's aside the point. And they've again promised in the last week that they'll extend it to people over 65, get rid of co-payments, et cetera, for seniors. All of this is in a program called OHIP Plus. So what that leaves is in this province, if people from age 25 to 64 will still have no public coverage. That's the reality, but still better than many other provinces. Finally, you will hear people say tonight and elsewhere that pharmacare would save lots of money, billions of dollars. Yes, it has the potential to save a lot of money, but there are always trade-offs, and we can't ignore those. Pharmacare doesn't mean that every drug would be covered for every person. In fact, public formularies, and a formulary is a list of drugs that are covered by an insurance plan, tend to be much smaller than private formularies. About 4,000 drugs on a public formulary in Ontario, about 12,000 on a typical private formulary. So they're very different. There will be fewer things covered if it's all public. That's the reality. Not necessarily a bad thing, but reality. Finally, just as important as the potential cost savings are the shifting of costs. What pharmacare really means is transferring the cost of private drug plans from employers to the state. Again, many countries do this, but we have to be clear that we have to pay for that. We have to pay for it with higher taxes or by a new tax on employers. So I'm going to stop there and welcome any comments or questions on that brief survol. Great.
So I'm going to try to keep us on track. We have time for a couple of questions. I don't know if anything has come in over the telegraph. Okay. We have time for a live question in the room if anyone has a question for Andre at this point. There'll be plenty of time you're with us for a little while? Yeah, that's wonderful. Okay, great. Thank you very, very much. Oh, yeah. Would you like the microphone we need the microphone for recording purposes. Yeah, thank you.
Hi, thank you very much. I'm Kelly Gorman. I work with the Canadian Cancer Society, so I appreciate what you're talking about around take-home cancer medications, and then even just talking about pharmacare and also, that trade-off, given that we do have, private insurance and government. And I don't know if maybe you have spoken about this, but do you have an opinion on what you think a model should look like for Canada?
I have an opinion on everything. I'm an opinion writer. No, I think my opinion is we have to decide. We can do an all-public model if we're willing to pay for it. My sense is there's a reluctance to do that, to have that grade of shift. If you look at the numbers, if you have a national program, it would mean a shift of about $27 billion to tax dollars. Now, this money is all being paid now, so the question becomes, do you want to pay it out of the left pocket or the right pocket? But there seems to be a reluctance. We live in an era where there's a reluctance to have more government spending rather than private spending. So I don't think that's politically palatable. So I think what's realistic is kind of a mixed model the way it exists in Quebec. Quebec is the one province now that has pharmacare, and what it has is mandatory drug insurance. So I live in Quebec, I have to have drug insurance. If I can't afford it, I can buy it from the state. And if I can't afford that, it'll be subsidized for me. So that's, again, the model that many European countries use. It's mandatory, and then we'll help you pay for it. So, but I think whatever model we take, it's essential to have this principle of nobody's denied essential care, and then we have to have the tough debate of what drugs are essential and which ones are not, which is a tough discussion.
Good question.
Yep.
One more.
Thank you. You mentioned that Quebec has pharmacare. Would they have fewer drugs in their formulary than you'd find in other provinces? And if the rest of the country moved in the direction of Quebec, would we suffer the same fate?
Yeah, so I wouldn't hold out Quebec. I think philosophically Quebec's a good model. Practically, it's not a great model. It's poorly administered. The costs are out of control, et cetera. They actually have a very large formulary because drug companies are based in Quebec. That's the political reality that things tend to get listed in Quebec much more quickly, especially brand name drugs. So they don't have a much more extensive formulary than Ontario, for example, where all the generic companies happen to be based. Purely coincidental. So, you know, good idea, but I wouldn't totally copy their model nationally.
We have one more question.
This is a discussion that I have with plenty of other mothers who run into the same situation as me. I've been to the doctors for my 1-year-old daughter a handful of times since 2018. I've been prescribed at least 3 different prescriptions, all of which our pediatrician has told us should be covered under the new OHIP Plus program. Out of the 3 prescriptions I filled, only one of them was actually covered, and in terms of price, it was the cheapest of the 3. Mind you, these were not just simple prescriptions, they were for serious matters, one of them being croup. My question to you is, what exactly does OHIP Plus cover? Because so far it seems that 90% of the prescriptions that my daughter has had have not been covered.
Yeah, so we have to remember OHIP Plus is very new. It's only been taken in place since January 1st. So the formulary is the same formulary as the Ontario Drug Benefits Plan. Has it been, I don't think it's been adequately adapted to children, to be honest. They've extended it to this new demographic and they haven't adjusted the formula. I think this stuff will be worked out. There's a lot of kinks in the system now. I think the mistake people have made with OHIP Plus is assuming that everything would be covered magically, and it's not, for better or worse. But you know, that's an example of children shouldn't be denied essential drugs because their parents can't afford them, right? It's illogical. It's going to cost more money to the system. And we have to figure out a way to do it, whether it's this OHIP Plus or another model that another party has. It doesn't matter what it's called, but we have to embrace that philosophy. And it's nowhere more important than with children, I don't think.
Great. Thank you.
Thanks.
Thank you.
Thank you.
I hope we can call on you again through the evening if the question is in your purview. I'd like now to introduce our panel of 3 people who are going to bring their lived experience to the conversation. The first person I'd like to introduce is Zal Press. I would also like to invite our 3 panelists to come up to the table while I do this. Zal has been living with Crohn's disease for well over 30 years, began his busy patient advocacy career 7 years ago, establishing the Patient Commando organization. Brianne Moore, at this end of the table, is a member of the Canadians CADM for access to depression medication, correct? And a longtime mental health advocate who was the Royal Ottawa's 2015 Inspiration Award winner. We also have Anne-Marie Serrato, a lung cancer patient with first-hand experience of Ontario's healthcare system and an active volunteer with Lung Cancer Canada. So I'm going to give each of our panelists 5 minutes. Come to the podium, if you will, beginning with Anne-Marie. And then we'll hear from the other speakers and leave sufficient time again for your questions and answers. Thanks, Anne-Marie.
Shall I time or will you?
You can time too.
That's okay. Good evening. My name is Anne-Marie Serrato. I'm 39 and a lifelong Ontarian. 9 years ago, in 2009, I was diagnosed with stage 3 lung cancer that eventually became stage 4 in 2011. That was before I knew anything about driver mutations, targeted therapies, or immunotherapy. Back then, I had little hope and thought I'd live a year or two at most. I didn't think I would get married or buy a house or even see my 35th birthday, let alone my 40th, which I'll celebrate in May, very happily. I thought my fate would be like the approximately 7,000 Ontarians who succumb to this disease every year, but I'm lucky. I have a type of lung cancer that can be treated by one of the many new revolutionary treatments. I stand here today because of these breakthroughs and innovations in lung cancer treatment and care. I'm also here to represent the 10,000 patients and their families who are diagnosed every year in Ontario. To put that number into perspective, the populations of both Kapuskasing and Smiths Falls are both less at 9,000 residents. I represent a cancer that kills more than breast, colorectal, and prostate cancers combined. One of the main reasons for this is due largely to late-stage diagnosis. Most patients are often diagnosed after they present with symptoms or become very sick, and usually are stage 3 or 4, when they require intensive treatment and follow-up, which can cost our healthcare system $48,000 or more per patient. We need to do better. We know screening can save lives. Ontario has been a leader on that front. Across the province, we currently have 3 pilot studies in progress. What these studies have found is that lung cancer screening programs save time and money. They save time because physicians can identify at-risk patients and automatically send them for screening, which consists of 3 consecutive low-dose CTs. By targeting this high-risk population, screening is more efficacious and takes fewer screens to find an early-stage lung cancer patient than it does with population-based screenings like breast cancer programs. Dr. Cressman of the BC Cancer Agency found that when you catch a lung cancer earlier at stage 1 or 2, it is much more likely to be curable, requiring less intensive treatment, and that there's a savings of about $15,000 per person treated. We're calling on all the parties to continue to support these pilot projects and turn them into permanent programs because we can save lives. I mentioned before that I would not be alive today if it weren't for new treatments that revolutionized how we treat lung cancer and other cancers. Treatments that have added years to my life, allowing me to do all those things I thought impossible in 2011, to travel, to fall in love, to get married, and even buy a house. They've given me something so precious and priceless: time. I was fortunate, though, in the right place and at the right time, and I accessed treatment through clinical trial. Many patients, however, aren't as lucky and are playing the waiting game. Breakthroughs are happening, but our system hasn't kept pace with these developments, and Ontario is falling behind in getting these treatments into the hands of patients who need them. 2 of the most prominent barriers are accessibility and affordability. For example, crizotinib, the drug I was first on, was approved by Health Canada in April of 2012. It wasn't readily available to patients until 1,486 days later, more than 4 years after Health Canada's decision to list it. Up until that point, a patient's only choice was to withstand IV chemotherapy, radiation, and sometimes surgery. I myself endured 6 months of intensive treatment, requiring frequent hospital visits and toxic treatments that have left me with side effects that haunt me to this day. When I began crizotinib, my treatment consisted of a take-home oral therapy with far less visits to hospital and less side effects. My life almost became normal again. It allowed me to do all the things I wanted to do and even more. Lung cancer patients can't wait a year or more, let alone 4 years for treatment. Not only do patients have to wait, they have to pay. Patients shouldn't be penalized for requiring oral cancer treatments. In Ontario, if I needed an IV infusion, meaning treatment through an IV, I leave my oncology consultation with an appointment for my infusion and never see a bill. If I were a patient in BC, for example, and needed an oral treatment, I would leave my consultation with a prescription and be able to have it filled at the pharmacy with no copay. However, as a patient that requires an oral chemotherapy in Ontario, I require my oncologist to fill in and fax an exceptional access program application, wait for deliberation. If approved and I have no private insurance, I would then have to apply for Trillium and wait again for a response. The wait time for Trillium approval, according to the Auditor General, was 19 days on average. If approved, I would then be required to pay an annual copay of 4% of my annual income upon my first dispensation. It's not a very user-friendly or efficient process. Ontario is falling behind. Patients don't have time to wait. In the spirit of national discussions, accessibility, affordability, and appropriate use, we understand that these drugs are very expensive, and we must be responsible for public funds. So I call on all parties and stakeholders, manufacturers, patients, government, and clinicians, to come together to modernize our system with innovative solutions so that the appropriate patients get timely access to the treatments they need. We have no time to wait. Thank you.
Thank you very much, Anne-Marie. Next, we're going to hear from Zal Press.
You know, the last email I got said 7 minutes, so I think I'm going to be speaking really fast tonight. You know, really hard to do that since 37 years ago. You know, is when my journey started, and I was feeling, you know, it was a cold Friday in November, you know, those kind of chilly, damp, miserable kinds of days, and I was feeling like there was a cat trapped inside my gut trying to claw its way out. So a completely disrupted intestinal system landed me up in a hospital that day, that afternoon. It was, you know, Toronto General Hospital, it was the emergency department, it was crowded even on a Friday afternoon. And I waited there for hours and hours, and it was 1980, not 2018. And I was waiting there for hours and hours. It turned out to be over 8 hours, and then I was on a stretcher in the hallway. And when a physician finally came up to me, and you could see he was like way overtired, and he came up to me and he said, "Mr. Press, you have a serious illness. You have Crohn's disease." And with those famous words, my life changed forever. I was no longer just a regular guy. I was a Crohn's patient. And everybody started talking to me differently, looking at me differently, especially my mother. Now, I was told at that time that there was no cure, it wasn't caused by stress, and that I would need to be on a diet of drugs and have surgeries, probably more than one. At that time as well, in 1980, there were no smartphones, no cell phones, no wireless phones, no internet, and cable TV, for those of you who might remember, was a push-button box attached to a TV by a cord. So there was only one book on the subject, and there was a small group of parents who had organized themselves to create a little association to support each other. Now, all of us were looking for better choices than an unending diet of drugs and surgery. But choices weren't part of the treatment plan. Physicians controlled that. Pharmaceutical companies, other types of private enterprise, the research community, and a bureaucratic political system controlled the rest. The entire system was geared to provider needs and severely limited the choices of people who actually required care. So I know you're going to ask me now, all of you, so Zal, what's changed in 37 years? Well, I've changed. And if you look at patients in a universal way, patients have changed. We have the internet now. We have access to information. We share that information. We share our experience. We share our stories. And people are connecting now in ways that I couldn't really have imagined in 1980. Now, patients are also participating as partners in healthcare and sharing in the decision-making that's really affecting their lives. And our notion of community, the sense of belonging, is no longer restricted to the physical boundaries of our local neighborhood. And this has allowed us to organize thousands of grassroots organizations that are on a variety of missions dedicated to better outcomes for all patients. Now I know you want to ask me, so Zal, what hasn't changed in 37 years? Well, whether it's the professions, the research community, policymakers, private enterprise, the drug industry, the culture of healthcare has not changed. So I've been asked to ask our politicians a few things and tell you what I want. So, what I want from someone who's had thousands of interactions with the healthcare system, I want a whole system transformation. One that focuses on improving the human experience as the sole driver of every decision that affects change. I'm not asking for a lot. I want policymakers and other healthcare stakeholders to stop treating me like an infant. Snappy little slogans like hallway medicine don't advance the conversation. I was diagnosed in a hallway 37 years ago. Fear-mongering around wait times is just not acceptable, whether it comes from politicians or angry physicians. It demonstrates a complete lack of appreciation for the lived illness experience. There are over 1,700 health-related charities in Canada, and I want policymakers to stop playing one against the other. You can't make promises to one that you're not about to make to the other. You can't play the diabetes people against the cancer people, the arthritis people against the Crohn's people, etc., the mental health, and etc. You just can't do that. It's not right, and it's just not right. I said that twice, right? Deliberately. And you need to better understand the impact on a person, and thank you for your comments, Anne-Marie. You got to make sure that you understand the impact on a person when restricting them to a drug plan that only covers 150 medically necessary drugs versus other populations who have access to over 12,000. Thank you. And lastly, don't tell me that you're going to find efficiencies in a system that's had a zero budget increase for several years. To me, the word efficiencies is political speak for cuts. And believe me, I've had numerous cuts on my body. It's painful any way you look at it. So what I need is a system that's responsive to the needs of the 21st century, not one that's over 100 years old. More than 14 million people in this country are over the age of 50, and that population is growing. And 50% of that population is being treated for one or more chronic illnesses. The preponderance of healthcare interactions are not taking place in hospitals. Yet we continue to invest vast sums in institutions that don't serve the needs of the 21st century population. It took me just recently, last 2 weeks ago, it took me over 2 months to get a photocopy of my medical records from Mount Sinai Hospital, yes, that great institution just up the street here. And it was a photocopy, took me 2 months to get it, and they could not deliver a digital file. So what we need is a system that's designed by patients for patients. The voices of patients and families are getting louder every day. There's strong evidence that increased patient and family involvement results in better individual experience, better population health, and a better culture of care that results in better health outcomes, all at a lower cost. Now, this explicitly means a transfer and sharing of decision-making power. We now have a Minister's Patient and Family Advisory Council. Well, that's a big first step, but it's a minor step. The next step is to establish a portfolio for an Assistant Deputy Minister of Patient Experience. Lastly, because I know time's running out here, I'm going to get the hook. I know what we need, finally, is respect for human dignity. I know many of you are thinking, hey, Zal, there's been lots of changes. And I'd agree. There have been lots of changes because it's easy to tinker with the system. God knows we spend billions on consultants to fix things that other consultants break. But what we haven't seen is real change. And that is the full paradigm shift from a provider-centered system to a truly patient-centered system. Governments from each of the major parties has had a kick at the can in governing over my lifetime of chronic illness, and each one has failed miserably to appreciate the patient experience and how the goal of reducing suffering, reducing pain and anguish, is the only measure of success. And here's my proof. If all the stakeholders really cared about the patient experience more than their own self-interest, we would have solved the single most compelling and complicated issue in the entire healthcare universe. And what is that? It's the hospital gown. So my final ask to our legislators is what we need is courageous leadership. So who's ready to step up to the task? Thank you kindly.
As a patient advocate myself, I'm not going to cut off another one who's speaking that passionately. Thank you. Brianne.
Hi, everyone. My name is Brianne Moore. I am 20 years old. I live in Ottawa, Ontario, and I am here today with Canadians for Equitable Access to Depression Medication. And I myself struggle with several mental illnesses, one of them being depression. I first experienced depression for the first time when I was 13. I had dealt with anxiety since I was 3, so struggling was not something that was new to me, but depression was. I didn't understand why I felt so low and why doing daily activities was taking so much difficulty now. I was having difficulty getting out of bed. I was acting out in school and getting in trouble with my teachers. I wasn't having fun with friends anymore. I remember crying all the time over the littlest things, and I began self-harming as a way to cope with what I was going through. I started therapy and I reached out to those that supported me and said I wasn't doing well and got the services that I needed to start working through some of my problems and talking about things that were going on in my life. But shortly after starting therapy, I realized that I was not getting better. Now, therapy is a process. Of course, I was 13 and I just wanted it to happen now, and I wanted my life back in that instant. But after being in therapy for a few years and it still wasn't helping me as much as I would have liked it to, I reached out to my family doctor to talk about medication. I heard that medication and therapy is a very effective combination for those struggling with mental illness. So I reached out to my family doctor and I was given a prescription. I was told it worked for a lot of people and it was a good starting point for someone who hasn't taken depression medications before. So I went home. I would have been about 17 now, so quite a few years, and I had my prescription and I got it filled and I began to take it daily. I'm very, very bad at taking my medication, but I continued to take it daily. And after 3 weeks or so, I realized that there wasn't a major difference. I had a follow-up with my family doctor and I shared how I was doing. And she said, well, you should have seen a little bit of improvement by now, so let's try upping your dose. So we did. And not only did I not get any better, but I became significantly worse. I was angry. I was not getting out of bed, even more so than before. And I started acting out with my family, and I wasn't communicating as well with them as I had been in the past. So I went back to my family doctor, and at this point I was kind of mad because I thought this was going to work, and I was told that it worked for a lot of people, so I was so frustrated. Why didn't it work for me? Because I want my life back. I stopped taking psychiatric medications for a little while. That did put me off a little bit, but again, I said maybe we'll try again and give it a fair chance. So I went back to my family doctor and I started a new medication, and it seemed to be working quite well for me. The thing about psychiatric medication is I was just feeling okay. You know, you're constantly looking for that medication that's going to make you like really have a difference in your life. But sometimes maintenance is the best that we can get at the time. And that is what I did. I just tried to maintain and keep myself well enough to attend therapy, attend school. I was still 17 and I was now living on my own. So not only was I trying to find a medication that worked for me, but I had the burden of paying for them by myself. And that being said, still completing high school, I was unable to pay for my medication by myself, and without doctor's discretion, I stopped my medication. Do not recommend that. And that happened several times because I was not able to pay for those medications. That being said, now I am covered by Ontario Plus, or OHIP Plus, sorry, but I still do not have access to innovative depression medications. Now, these medications could make a huge difference in the lives of folks like me who maybe are not responding well to other psychiatric medications, the one that are more common and work for a lot of different people. What I didn't know at the time is there are actually 229 different combinations of depression symptoms. So what works for me might not work for someone else. Everybody's depression is different and everybody's treatment is going to be different. I've been on probably 6 or 7 psychiatric medications in the last 3 years. That's just depression medication. I've also tried some different anxiety medications, still in therapy, different combinations, and I have yet to find a combination that really does make a difference in my life. Like I said, I've had 6 or 7, and about 4 or 5 of them have actually made me significantly worse. So my ask to the politicians and the MPPs in the room today is, what difference can you make in the lives of folks like me who are not able to access those innovative depression medications? And for people who are experiencing the same issues that I had, you can't afford your medication. No Canadian should have to choose between taking their psychiatric medications or paying for dinner. Thank you.
Thank you, Brianne. We do have time for some questions. I'm going to look to Martine to ask if anything again has come in over the system.
No, nothing is coming through the system. It's plugged in. Please do go on to Slido and .com, and the code for today's session is 9336. And if you do have questions, you can type them in. But I know we have some probably in the room, so I'm going to pass it over to
Let us know if your question is directed to one of our patient advocates or to the group. Up to you.
Hi, my name is Samantha Tanner. I've been a patient in the healthcare system of Ontario since the age of 3 when I was diagnosed with acute lymphoblastic leukemia. As a result of some of those treatments, I'm now living with schizoaffective bipolar type disorder. When I went to find a psychiatrist, I had no choice but to go to the emergency department and pretend I was suicidal. Because there is a shortage or a long wait times to see doctors, and I want to know, this is to the politicians and the MPPs that are in this group, what they're willing to do for the state of our mental health system in Ontario. Thank you.
Thanks. Would that be okay? We can ask France Gélina to respond to the question as one of the representatives of a political party, and we can respond to the question after her presentation. Is that okay? Yeah. Thank you for the question. Yeah.
I can go now. I could go now. It's just
Up. Yeah. That's fine. Thank you.
We have a question? I have a question, if I may. I'll take the prerogative. What advice...
Micro, s'il vous plaît.
My microphone is over there. Oh,
It's important for recording.
yes, no,
the session.
sorry.
Yeah.
What would be your advice to other patients? Because I think of, the people that I meet when I go through the healthcare system, either myself or like that I look around, and you're obviously very savvy patients. You've navigated the healthcare system. You're engaged. But what do you say to like your neighbor who's going through an experience like you? Because there's way more of those than there are of you. Who wants to take that?
It's mine. Oh, good. So I was given the option of going home and waiting until I had symptoms before I got treatment, which basically to me meant go home and die. And so when I found my clinical trial, it was me that found my clinical trial. And so I would advise to patients that aren't getting the answers they want or treatments they need to keep persisting and keep working the system, because no one else is going to advocate for you, really. You have to be your own advocate. And so keep strong and keep going and keep on people, because it's the only way we'll get change. Anyone else? Yep.
Just adding on to that from a mental health perspective, I've been in and out of the system since I was 13, and I've been referred to a lot of programs, and I've been denied from a lot of programs. I find personally in my experience, it's either been I've been doing too well for a program or I've been too sick for a program. There's not a lot of in between or gray area when you're accessing services in the mental health system. So adding on to that, the exact same thing is just to keep asking for what you need, and you know yourself best. You know what your needs are, and to fight, because you have the right to get treatment.
I'm of an opposite mind. I don't like to tell people anything, to tell you the truth. And think about it, you know, to the women in the room who've had children. How many of you were told before you had your first child by another woman who had children, you know, really what you were going to be going through? So, you know, people are a little bit reluctant to tell. And the key thing here really is that the patient experience is more about listening, not telling. In fact, the experience that most patients have is that they are not listened to. And the data tells us that physicians will interrupt a patient anywhere from 12 to 18 seconds into their story. So for me, it's more of it's more important to offer that individual the opportunity to share their story. Stories are where we find meaning. And we've been doing that, you know, ever since the days of caveman. They've been writing on cave walls. And we raise our children on stories. You know, if I told you, you know, how does this story end? It starts with once upon a time. You would say, well, they lived happily ever after, because we're raised on stories. So for me, when I'm asked to speak to a patient, I don't speak to a patient. I ask them to share their story. And I think if any of you, you know, are faced with that kind of a situation, wondering, what do I do? What do I say to this person who has cancer, who's just been diagnosed with a life-threatening disease? What do I say? How do I say that? How do I show empathy? How do I show compassion? How do I understand this as from the human perspective? Because that's what it is. You're not going to cure them simply by listening to their story.
Martine, I understand that you've received a question.
I have, and it relates to pharmacogenetic testing, and wondering if there would be some standard tests that would be helpful for patients, especially maybe in mental health, Brand, because of your experience in going through many treatments. Would that have, if it was available, made a difference, I guess, to you?
Other than receiving the basic diagnosis of this is what you have, there were not a lot of tests done to look into what would work for me or what would work for my diagnosis or me and different things. So yeah, those tests would be helpful in being able to explore more what things look like for different people that are struggling with different illnesses. Again, mental health is not a one-size-fits-all. Everyone's going to struggle differently. Everyone's going to have different symptoms. We need to make sure we're looking into that more.
Thank you. I'd like to keep us on track now by moving to the next part of our program, and make sure that you save your questions for later in the program. So, by all means.
I just wanted to say it wasn't. It's yeah. My name is Joan Paulin, and I'm a patient advocate for the Pulmonary Arterial Hypertension Association. My daughter was diagnosed with severe PAH when she was 24, and what all of you guys said resonated with me. The reality of it is, not only does the arthritis have to fight against cancer, against diabetes, rare disease has to be included in that conversation, because all of our children need access to medicines. Thank you.
Thank you. I'm now going to invite our next two speakers to come up. I'm going to thank our patient advocates for the very concise and very systemically oriented issues that you raised, talking about your own lived experience. Thank you very, very much. The next two speakers are welcome to come up, Louise and Phil. We're going to hear first from Louise Binder, who's a very active health policy consultant residing in Ontario. Louise has received numerous awards for activities in representing patient interests. And Phil Upshaw is a member of the Access to Depression Medications National Leadership Team and Senior Policy Advisor to Mood Disorders Society of Canada. Louise, can I ask you to come up?
Absolutely.
Good news.
Good news, it adjusts. Well, Anne-Marie already sorted it out for me.
Our speakers each have 5 minutes.
And I actually got my words down to 5 minutes. First, I really want to start by thanking our speakers and our political colleagues for joining us on this busy budget night. And I really want to especially thank all of you in the audience for taking such an active interest in the democratic process. A process that in some parts of the world, even some not too far from us, is certainly facing some credibility challenges at the moment. So I've been working in health policy for patients for 25 years. I'm almost catching up to you. And I've certainly learned, if I've learned nothing else, I've learned that there's often a huge gap between how we think the healthcare system works and how it really does work for patients. And I'm going to refer back to some of the things that our patient experience panel told us and try to talk about those a little bit in a systemic way. In my view, politicians are part of the knowledge gap about what really happens, and the media are too. They speak in sweeping terms about universality, sustainability, which Andre has clearly pointed out is a bad idea, and accessibility. But what do they really mean by these terms? How many of us actually believe that we have universal health care? Don't raise your hands. How many of us know what governments are really offering when they promise universal pharmacare? Do raise your hands. I'd be very interested to know if any of you know that. I don't. Not knowing the answer to these questions does not mean that you are ill-informed. In fact, it probably means that you've had the good fortune to be spared ongoing involvement with the present healthcare system. Canadians have been told forever that we have a universal healthcare system. We think this means access to all aspects of the system, including hospitals, doctors, and medications. We think it means it's for everyone. And we think it means equal access across Canada. I regret to inform that this is as untrue as the existence of the tooth fairy. The federal government contributes funding for doctors and hospitals, but not enough to stop the often long wait times for appointments, treatments, and surgeries. And not every service we need from these people is covered. And we get limited time due to fee schedules and busy practices. Drugs and many other services, as Andre has pointed out, are covered solely by provinces and territories. Each builds a health budget based on its own economic engine, demographics, geography, other overall budget priorities, interprovincial health activities, transfer payments from the federal government, and no doubt a large other group of alchemy that I don't know anything about. So each province's service clearly is going to vary. It can't be otherwise. Health budgets are then siloed for drugs, hospitals, doctors, administration. And once the amount allotted for that silo is exhausted, no more can be spent there. A fundamental weakness with healthcare in my view. That's one of the fundamental problems with our system. I will never recall sitting with the person who manages the budget at Cancer Care Ontario to talk to him about people I knew who really needed some treatments they were not covering. And he looked at me seriously and said, "But Louise, I don't have any more money in my budget." And I responded, "Well, would you like me to go back and ask these patients if they could please get cancer next year, and preferably in January or February before the budget gets exhausted?" He didn't laugh. I'm not suggesting that there are villains in this piece. I actually think that the problems are systemic. We have a system dealing with rural and urban issues in a huge geographic country with diversity of needs and income disparities. So all that said, I'm actually an optimist. And like Andre and like Zal, I believe we need revolution. I believe in revolution. And by the way, if you know the history of revolutions, they're almost always started by doctors and lawyers. So we're in good company. So what do I mean by that? What I mean is that I believe sincerely that we can develop a healthcare system that is value-based. And by that, I mean value for patients as defined by patients. That is affordable, and Andre, forgive me, sustainable. If we had this kind of system, the comments that our panelists gave us about having to fight for things that they needed would not happen. Those values would be built into the system. They wouldn't have to be fought for individually. I know that it's going to take time to turn this mammoth ship around, but I would say to you that it's worth it, not only for this generation, but for future generations. And as long as I'm doing this work, that's what I'm going to be fighting for. But presently, until I get what I want, I look at health policies in Ontario, and we're really looking at them right now because it's pre-election, and I ask myself, is this policy getting us closer to value-based healthcare or not? And that's how I evaluate it. So let's briefly look at a few key Ontario health policies under discussion now. OHIP Plus. There's been quite a bit of discussion about OHIP Plus. I would give it 1 thumb up and 1 thumb down. It definitely provides access to publicly funded drugs for people under 25 without other coverage. And that is excellent. And I'm so pleased that it was of some value to you. I'm really happy about that. The problem is that the province decided to be the payer of first, not last resort. So the under 25s who fortunately do have private health coverage, or I guess did have private health coverage, and who therefore didn't need OHIP Plus, may well have lost that coverage. And that adds unnecessary costs to the public system, as well as meaning that they may well not get the same drugs that they were taking previously through their private plan. And the reason for that is that public drug plans are limited in what they can afford to cover, thereby making choices. They often choose generic drugs, a wise use of taxpayers' dollars. However, not all drugs that people need are generic. So that's what I think about OHIP Plus. Cancer drug coverage, and a resounding 2 thumbs down. In fact, I wish I had 3 thumbs. Until Ontario catches up with most of the rest of the Canadian provinces by covering take-home oral cancer drugs, it just gets a completely failing grade. Realistic dental coverage. Now, you will note I said realistic dental coverage. I am all thumbs up for realistic dental coverage. This is long overdue. Mental health funding, in principle, of course I agree. I will leave it to my much more knowledgeable colleagues in the mental health field to describe whether we're where we ought to be or how we ought to get to where we should be. Home care, in principle, 2 thumbs up. The problem is that we are not covering many things that go along with keeping people at home, including drugs in the home, and this is a very serious problem. But in principle, we have to move that way. And I think it was Zhao who talked about the fact that so much goes on outside a hospital. And that's absolutely true, and therefore we should be organizing ourselves in that way. That's value for patients. Appropriate hospital budgets. I completely agree that I absolutely do not think we have our hospitals organized appropriately, and when we get to value-based health care, we will. That's exactly part of the principles of that system. But we need to be sure that there isn't waste and duplication and inefficiencies, by which, by the way, I do not mean cuts to services. I mean, why is it that I have 5 specialists in a hospital, and every time I go to speak to them, it's as if they've never seen me before, and I'm telling my story all over again. That's real inefficiency. And we don't need any more high-priced hospital administrators. Patients should be meaningfully involved in determining how these budgets are allocated. In fact, patients should be involved in how all health budget items are allocated. Daycare. In principle, all thumbs up to daycare. Removing this barrier to work and schooling is fundamental. Education, training, and employment are all social determinants of health. In fact, when we get to value-based health care, we are going to tear down the walls between social and legal problems, and they are going to be integrated with health because we know that they are synergistic, and we cannot get one without the other. Pharmacare, my favorite. I give it a qualified yes. But is it the OHIP Plus model? If it is, great, more people will be covered. However, if it's going to cut off private coverage and add unnecessary burden to the system, or create a situation where some provinces do less than they are already doing in order for equality across the country, I'm not voting for that. So many issues, so many questions in this election. These are but a few. If you're interested in working together after this meeting to deliver our messages to politicians beyond those who are here tonight in the run-up to the June 7th Ontario election, please let us know. Thank you.
Thanks, Louise. Phil Upshaw.
Just carrying my iPad so that I don't forget it. And if anybody sees me walking out of here without it, please remind me, don't forget your iPad. It's always nice going last at these events because when I do, everything I wanted to say has already been said. So I don't have to really add any value to the discussions. I agree completely with everything everyone has said. I admire the strength of Brianne and all of her willingness to get involved. I'm just going to ramble around until they cut me off. How's that? Is that fair? Number one, mental health is something that I have lived and experienced for the last 30 years, mental health issues, illnesses. The first time I heard about it, because I'm an old guy, was in the 60s when a former premier of ours, John Robarts, blew his brains out in London, Ontario, committing suicide, obviously, having lived with depression, which was then not known as depression. I was politically involved at the time and shook my head, and I couldn't understand how anyone as successful and as happy and a wonderful guy as he was, if you happen to be a Tory, he was a wonderful guy, and he just kissed everything goodbye. So after that, my next experience was waking up in a psych ward. And I have to tell you, Zach, that that's a little worse than waking up in the hallway of any hospital. I don't think there's anything worse than a psych ward when you happen to have to experience the way your issues are ignored, the way you're treated as a less than a human substance, a person, and it really ticked me off. But I'm not going to get into that because I'll get all mad. When I recovered, I decided to do something about it, and I've always been involved in things. So I went to the national level, the federal level, to talk about mental health issues. It seemed to me that the federal government was the funder of health care, and they damn well should be putting money into mental health care. And I could not figure out why it wasn't going there. When I got to the federal level and started to knock on doors, I had the great pleasure of knocking on Anne McClellan's door, Alan Rock's door, and Ujjal Dosanjh's door, all ministers of health, all of whom asked me to get out of their office, go back to the provinces. That's where mental health care is looked after. We don't care about mental illnesses. They did have a mental health promotions department, as ineffective as it was at the time, but they had absolutely no interest in funding mental illness issues, which is hospitals and Medicare generally. So I tried to build a little bit of a coalition, but found that the national NGOs at the time had absolutely no desire to spend any time with someone representing mental illnesses. Cancer, kidney, diabetes, very important NGOs, but they were afraid that if mental illnesses got their rightful place in the advocacy network, we would take over so much of the funding that so much of their funding would be cut off. So in effect, I was cut out. We then formed a coalition called the Canadian Alliance on Mental Illness and Mental Health and started to build a bit of a strong voice just for mental illnesses. It's hard to build a strong voice for just for mental illnesses when almost every chronic disease is also associated with mental illness, principally depression. But so when you talk about depression, you have to talk about rheumatoid arthritis. You have to talk about cancer. You have to talk about coronary disease. You have to talk about recovery from any kind of operation. As we move forward, our great benefactor at the time was Senator Michael Kirby, who undertook his study on mental illnesses and subsequently gave arranged for us to have the Mental Health Commission of Canada. Patrick Dion, sitting in front of me here, is one of the first vice chairs of the Mental Health Commission. I continue to have the honor of being the senior policy advisor to the CEO of the Mental Health Commission. So it's been a very interesting period of time. We need access. Access is a big deal. Everybody talks about access. We need access to medications, obviously, and I'll end with that. We need access to hospitals and doctors. Wait times, if you've ever had an issue, a mental health issue, and ended up in emergency, the one thing you find out is that the nurses and the doctors don't think you're sick. So you'll be triaged to the last possible person who could be 24, 48 hours waiting for help. Many, far too many people leave the emergency ward long before they're seen, long before they're diagnosed, and suffer incredibly because of it. So that's number one in terms of identifying the fact that mental illnesses are an illness. They are a very important illness. They need to be diagnosed early. The earlier the diagnosis, the faster the treatment can commence, and the faster the recovery. You're going to cut me off? No. I just started. No. Oh, okay. I thought I had 20 minutes. So I want to reinforce a couple of messages that you've heard, and then wait till he gives me the hook. I don't think, I've been involved in healthcare, generally speaking, for some time. I stick my nose into research into primary care and into patient advocacy. I do it not as a token and absolutely not as sort of an individual. I partner with researchers. If they're not interested in partnering with me, if they're not interested in giving me according to me, the fact that I am an intelligent individual who can make suggestions that should be followed, then I don't work with them. But there are enough researchers very anxious to work with the Mood Disorder Society of Canada and the organizations we're part of, that we can and we are influencers there. Same with primary care. Because we got involved with primary care, there's now an organization called the Shared Care Primary Health Care Network. Mental health has been a leader in moving that primary health care network forward. But my view is, as has been expressed before, we need an absolute reform of the healthcare system. It's not helping here and there is not going to work, and it's not going to work until we have patient-centered care. No, not just the baloney of the Canadian Medical Association saying we've got patient-centered care. That is just baloney. We need people who honestly believe in patient-centered care. We need people who honestly believe that it needs to be patient-centered care. And we need to understand that it has to be patient-engaged care. Patients must be engaged in all aspects. And as a matter of fact, from my perspective, patients should control the whole system. We know what's important for us. The doctors don't know what's important for us. They know what's important for us to tell us, for them to tell us. So to go back to medications, because that's why I'm here to say a few words to the politicians who had the courage to show up. We need access to medications. Medications are our wheelchairs. Medications are our canes. Medications are the things that help us get better. That's access. Medications that we need are medications that will not break us. We shouldn't have to pay for medications that are approved by Health Canada but are not on provincial formularies. We should be equally entitled to accessibility to medications the same way everyone else suffering from a chronic disease is. It's really not useful to have somebody have to choose between eating and taking their medications. So can I keep going? Can I keep going? Can I keep going?
Almost 10 minutes.
I want, if I can, thank you. We have a website, cadm.ca. Take a look at it. It's got all of the stuff I should have said and haven't said about. But the other thing that's just happened yesterday, while everybody was worried about the budget coming today, federally, there's something called the PCHO review was just completed. Andre did a great opinion piece on it this morning. I happen to be fortunate enough to have been involved in that. But I urge you to take a look at it. It's called the Pan-Canadian Health Organizations Review. Dr. Danielle Martin, many of you who know, was part of it. There's another fellow from University of Alberta there. But there are significant recommendations that will impact, if they're taken up, the future of healthcare and the provision of healthcare. Principally, and the only political thing that I think is sure to happen is pharmacare. And the reason I say that is because pharmacare is sort of highlighted throughout these reports. And of course, Eric Hoskins has just gone to the federal government. So if you're interested in getting involved with something that really will have an impact on medications and your ability to recover, take a look at it, get involved with the pharmacare debate with your local MP, push your local MPP to push your federal MPs and to push how we fix up the Ontario pharmacare. I guess I gotta go? Okay. Thanks very much, and if I missed anything.
Look, he left me his iPad. That's very kind of you. Thank you. The good news is that we actually still have a couple of minutes for questions so that both Louise and Phil may get another opportunity to expound on some of their favorite themes. Let's ask first Martine.
I do have a question here. To any of the speakers so far, what is the most pressing legislative change you would like to see at the provincial and federal level?
Legislative change. It's a good question.
You want to use the microphone there?
Can I be slightly facetious?
Of course you can. I'll give you
well, if I could have anything I wanted, I'd change the Canada Health Act so that drugs were included. And I make the joke that if the fathers of Confederation had been mothers of Confederation, I think we might have had that. I think at the time the provinces thought they were being very smart to leave them out. Little did they know how profoundly important they were going to become as part of a universal healthcare system. And I think this division of church and state, if you'll forget provinces and the federal government, you can decide who's the church and who's the state, is really problematic for us. The trouble, of course, is no one is going to have the appetite, I don't think, to open up that piece of legislation. But truthfully, that's the big change I would make.
Thank you. Phil?
I'd agree completely with Louise. There's so many. The problem we've had in the past is we have a patchwork of health care, mental health care, federal, provincial, who buys HTA approval, all the rest of that stuff. And no one's done a really wholesome, holistic approach. All Canadian activities, and quite frankly, from cities as well, regions where regional health acts are in place. If we could get some sort of a constitutional meeting together, change the Canada Health Act and a bunch of other things associated with it, we'd be a healthier country, and I would put a lot more emphasis on physical and mental health promotion. We should not have an illness-based system. We should have a wellness-based system that keeps people out of hospitals. How's that?
Thank you. Patrick.
Yes.
Thank you both, by the way. Very clear that you've been at this a great deal, and I certainly thank you, Phil, for the kind acknowledgement of our work together in the journey of the Mental Health Commission for the past decade. The question is actually directed to both of you. I know Louise will have a perspective on this, but Phil, if I may start with you. We have, as you properly point out, the politicians, I think as you described it, who courageously agreed to show up tonight. What might your question to Madame Gélinas, for example, be, given the journey you've had, particularly when it comes to the very passionate story that Brianne shares about the inequity of access, and particularly, and I'll use my term, the failings of OHIP Plus. Over to you, Phil.
I'll be very short and simple. When you have the opportunity to respond, Madam Gélinas, if you could comment on whether or not you and your party would be willing to undertake legislation and activity that would resolve our problems, particularly with access to medications for people living with depression. But I think probably with regard to all issues, quite frankly, that have arisen tonight with regard to access to medications, it's really important, and it gets people back to work. It puts money back in the till of the government of Ontario as opposed to paying it out. So I will leave it at that.
So one of the most appalling, maybe that's a bit strong, but not really, things I've heard was actually a quote, I'm sorry to say this, but from the Deputy Minister of Health in Ontario, Bob Bell. And it was at the end of a conference of our health technology assessment group in Canada, agency in Canada, and he was on a panel, and he was asked about mental health. And he said, 90% of mental health treatments could be managed through a general practitioner. And I know a lot about mental health, in addition to a few other things, but I do. And I cannot imagine 90% of the healthcare, mental health issues in this country being managed through general practitioners. If those of you who are greater experts in mental health than I think I'm wrong about that, I do stand to be corrected. But you know, just from your story, it's such a profoundly complex area of health. And to think that we're just going to, and I mean, no disrespect to general practitioners, but how could they possibly keep up with that and everything else that they're supposed to keep up with? It's not realistic. And I just think that we have to find a different paradigm, and we have to stop thinking that mental health, you know, it's easy to deal with. Oh, it's just depression, or it's just, I've heard lots of those justs, and they aren't just, are they? They're not just at all. So I think that was really disappointing to me, I have to say, and I suspect that he expresses a view that is shared by many, unfortunately, in power, and they need to be educated.
In mental health issues, we talk a lot about stigma. There is no stigma about mental health or mental illness issues as far as I'm concerned. It's straight discrimination. And I think we have to get back to using that word. And when I was in university, my professors in the first year always said, take a look to the right, take a look to the left, because one of you ain't going to be here after this year, and two of you ain't going to be here after year 3. And they were right. But take a look in this room just here. 1 out of 5 right now in this room is suffering from a mental health issue. Generally speaking, it's depression. It could be bipolar. But Canadians suffer hugely from mental health issues, and they suffer significantly from the discrimination that comes because we don't have access to universal access to medications that are approved, and we don't have access to the way we should to disability claims and to a whole lot of other things. I've added a little extra preaching.
The
another
timekeeper has
chance.
to step in for a moment, I'm afraid.
Do we have time for a question?
Just make sure that we get ourselves on track with the next session. So this will be our last question in this section. Go ahead, Christine.
I will make it a very brief question, and just to add on to what this panel is saying, I also wanted to ask what the politicians in the room and their parties are prepared to do in terms of cancer survivorship, because every 1 in 2 people in this room, according to the Canadian cancer statistics, will be due to get cancer in their lifetime. So, for example, Anne-Marie is on a drug that allows her to go back to work, but she was refused because she's too much of a liability. So, you know, we have somebody who's willing to go back to work, but she can't do it because the system won't let her do it. Well, what are we going to do to help cancer patients and look at the issue of overall survivability and access to medications that can allow them to have survivability?
I just want to make a plug for a book for which I have no investment whatsoever. And it's a book called Redefining Healthcare. And I carry it with me everywhere because it's the only thing that cheers me up these days. And it's a book written by Michael Porter, 2 doctors, Michael Porter and Elizabeth Teisberg. And if you read it, it really is a blueprint for how we can get out of the healthcare mess that we're in. And I hold it close because otherwise it's not a good day for me most of the time.
Thank you. Over to you, Ron.
Thank you. I'm now going to, first of all, a round of applause for our health policy analysts. Thank you. So now I'm going to invite the representatives of 2 of the 3 political parties who agreed to join us tonight, France Gélinas and Bill Walker. France will speak first. You will know her as the NDP critic and for health and long-term care. And France has been an outspoken critic of competitive bidding in the province's home care services and of layoffs affecting nurses in the provincial hospitals, just to mention 2 issues of interest and concern. MPP Bill Walker is currently the Progressive Conservative critic for seniors, long-term care, and accessibility, and has also served as the critic for community and social services, long-term care and wellness, children and youth services, and also as the Deputy Health Critic for rural and northern Ontario. France, will you join me here?
Absolutely.
Well, good evening, everyone. Bonsoir tout le monde. As it was mentioned, my name is France Gelina, and I'm the MPP for the riding of Nickel Belt, which is in Northern Ontario, one of this big northern riding. Smack in the middle of it, there's the riding of Sudbury, but I'm all the way around. If you've heard about nickel mines in Sudbury, they're in my riding. I've also been the health critic for my party, the NDP, for the last, it was 10 years in 2007. I'm in my 11th year as the health critic for the NDP. I come from 25 years in healthcare, started in about 1982, and spent about half of it in hospital and half of it in community care. And for the last 11 years, I'm a MPP. So I tend to start all of my talk with, we have a program in Canada that defines us, a program that we are all very proud of, that we call Medicare. And Medicare is basically, at the core of it, is that we care for one another, and care should be based on needs, not on ability to pay. And this was the spirit when Tommy Douglas brought us Medicare, and I'm really proud of that. But at the same time, what Medicare really is that if you go see a physician or if you go to the hospital, care will be offered to you free of charge. Everything else that is within our healthcare system, mental health, home care, long-term care, primary care, it doesn't matter if it is not physician or hospital, then it is a patchwork of services, some of them funded, some of them not, some of them privatized, some of them not for profit. And I think Monsieur Picard did a good job of laying out what this looked like, so I won't repeat it. So here we are in 2018. We've had a Liberal government for the last 15 years. So if we look at the two big pieces of Medicare, I'll start with hospitals. So in our hospital, about after the downturn in the economy in 2008, the government, trying to balance the books and everything, decided to freeze the base hospital funding. So their revenue stayed the same and the expenses went up. The first year that they did that, the zero budget increase for our hospital did pretty good. They looked at words that Mr. Picard doesn't like, but they look at efficiencies, and they implemented the lean, and they did all sorts of stuff, and they sort of kept it together and continued to give us care, and things went on. That was year one. Year 2, 3, 4, 5, and 6 were a disaster. Hospital could not cope with their hydro bill went up the same as yours and mine. The cost of drugs went up. The cost of collective agreements and staff and everything else kept going up, but their revenue stayed the same. And then we started to see a shift. We started to see a shift where entire units are not staffed anymore, and people are being admitted in my neck of the woods in a bathroom. A good friend of mine, Leo, was sick enough to be admitted into Health Sciences North in Sudbury. He was admitted in a bathroom, and he spent 13 days in there. Hallway medicine is, it started in our community hospital. It then grew into our large community hospital, and it is now the norm. If in our 152 hospital corporations, they are all the same. We started asking through Freedom of Access of Information for occupancy rate, and the general knowledge is that at about 85% occupancy, a hospital is in a good position to handle seasonal variation and that kind of stuff. We have hospitals that haven't been below 110, 120 hospital occupancy for months and months and months. What does that mean? That means that we now have a new word. It's called unconventional places. And this is how hospital CEO will describe people that are admitted into what used to be a 2 patients room is now a 3 or a 4, and what used to be a TV room is now a room for 4 patients. 4 patients that have no sink, no toilet, that uses a commode that everybody can hear and know that you are going to the bathroom. It is demeaning. It is, frankly, not meeting our expectations, is it? At the same time, I don't give people false hope. If we make government on June 7, is the NDP going to snap his finger and we're going to go out of this? No, it's going to take some time. But at the same time, we cannot continue the way that it has been going. If you look at the other part that is paid for, that is physician services, our physicians have not had a negotiated agreement in the last 4 years. You know what? At the core of every physician, there's a human being. And human being likes to be treated like human beings. Like any other workers in this province, they would like to have an agreement. They would have to have the opportunity to negotiate something that makes sense to them and the changing healthcare system, and they haven't been able to do this. So, 2 of the big part. Remember, the rest of it is a patchwork of services, so let's go into the patchwork. The first thing that, as an NDP government, we have put this out as a platform. My leader is called Andrea Horvath, and last year, at about this time, we put forward a plan for pharmacare. Don't get me wrong, like everybody else, there's 132 jurisdictions that have a Medicare, similar to what we have. All of them but us have a pharmacare attached to it. The most popular form of pharmacare that you will see is a list of medications that is available to all. So for us, our value is that we believe in universality. We believe that we will bring pharmacare forward that will be for everyone. I have nothing against seniors have access to drugs, and young people and children under 25 have access to drugs. Those are good drug plans, and I have nothing against this. There's some issues, and I could go into this, but this is not universal. Universal means that everybody has access. So what we will do is we will start here in Ontario. We will start with a list of about 125 drugs. We have tested it in 3 different sites in Ontario. With that, we're about to cover about 90% of the medications that are prescribed by family physician. Does it solve all of the problem? Absolutely not. But it will do like Tommy Douglas did in Saskatchewan 50-some years ago. He started Medicare in Saskatchewan. It grew to be through every provinces and territory, and it grew to be a program that defined us. It is high time that pharmacare be added on, with the view that as it grows, so with the formulary and so with the list of drugs. Second thing that my leader has promised is dental care. Why our mouth was excluded from Medicare is a mystery to me that I don't know why, but it is what it is, and let's change this. Mr. Picard said that government invests only 5% in dental care. In Ontario, it's 1% of dental care is paid by the Ontario government. So what are we bringing forward? First, we build public dental care. So making sure that community health center, Aboriginal Health Access Center, public health unit, etc., build up their dental suite. We make it accessible to everybody who is over 65, who don't work, will get access to dental care. Same thing with people on Ontario Works. People on Ontario Work right now have a patchwork of service. We will define a basket of service that will be accessible to all, basically prevention, medically necessary, including denture. If you needed to chew and to be healthy, it will be covered. So the basket of service needs to be covered, but this is what it will be based on. Publicly available to everybody over 65 and people on OW. On Ontario Work, sorry. For others, 3/4 of us have a dental plan. If they meet the minimum standard, you will keep your dental plan, nothing will change. You continue to go to the dentist of your choice, life is good. If you don't have a dental plan, then we will force every employer who does not provide dental benefit to pay into a provincial dental benefit. So they will have a choice. They can go and provide all of their workers with a dental plan. If they don't want to do this, then they will have to pay 1% of their payroll into the provincially run dental plan, which means that it doesn't matter if you are part of the gig economy, it doesn't matter if you work part-time, if you have contracts here or there, if there is money going to somebody who does work, there will be a charge if that employer does not give you a dental plan. So this is my 1 minute mark, and I still had lots to talk about. I'll go really fast about mental health and addiction. We absolutely need to do better. In 2008, I sat on the special committee for mental health and addiction. It was a miracle. We got a special committee. It was actually a member of the PC who brought it forward. I had just been elected a year or so before. I came from 25 years in healthcare. I knew it all. I saw it all. I knew nothing. I had seen nothing till I sat there for 18 months. We traveled throughout the province and saw how badly our mental health system failed people time after time with catastrophic outcome, and yet it did not trigger anything. We got together, all three parties, we stood in the media studio, all three parties together and said, this has to change. The priority number one, give mental health and addiction a home. So the NDP government is already on record. If we get elected, we will create a Ministry of Mental Health and Addiction to give mental health and addiction a home. Define a basket of services that has to be accessible to all, build on the best practice that already exists, make sure that it exists equitably throughout. So it doesn't matter if you come from Northern Ontario like I do, or if you are a trans person living in Toronto, you will all have access to a minimum standard of mental health and addiction services that will be under a ministry that will make sure that it is accountable, that it makes it happen, that it funds it. Right now we have 11 different ministry. At the time it was 13, it's 11 different ministry now. Some of them came to the deputations to the committee to tell us, we know we are not doing a good job. We don't know why we have mental health and addiction funding. Please take this away from us. We know we are not doing a good job. And that doesn't even start to talk to what he was talking about with the discriminations that exist within our healthcare system right now. Canadian and Ontarians have turned the page. We now have more and more people who come out and say, I need mental health care. And in my neck of the wood, if your child comes forward, is assessed and needs mental health care, he or she will be put on an 18-month wait list, because this is what it looks like in Nickel Belt when a child needs mental health care. And there's a good chance they will age out of the children's system, because children that are mentally ill are not ill. They're not part of the healthcare system. They're part of the children and youth system, and apparently it's because of bad behavior that those kids have a mental illness. I cry. Anyway, I don't believe any of that. A child who is sick no matter what the sickness. We need to give it a home. We need to do better. We need to our healthcare system needs to grow up to what the rest of the population has done. It's not right to discriminate. People are asking for those services, and they should be available to all. And my minute is probably over, but I also wanted to talk about disease prevention, the social determinants of health. How do we make sure that all of this works? You keep people healthy. The number one way to keep people healthy is income. For every $1,000 more you make, you can measure those people are going to be healthier. The NDP in 2010 was $10.10. We wanted minimum wage at $10. In 2012, we wanted it at $12. And since 2016, we've been asking for $15. Did you know that in December 31st of 2016, the minimum wage in Ontario was still at $11.45? This is how you make Ontario healthier. You make sure that everybody who works gets a living wage, and you make sure that nobody lives in poverty. There is enough money in this province to do so much better. The last 15 years, we have seen the rich get way richer and everybody else did not. This has to change. How do we pay for the changes that I've just mentioned? You make sure that the people who are wealthy enough to have high income pay their fair share. You make sure that corporations that are bringing in a healthy profit pay their fair share. And my minute is over. I will be happy to answer questions.
Thank you very much. Bill, I'll invite you to the podium.
Thank you very much. Pleasure to be here. So I'm here actually representing Jeff Urich, our health critic, and I actually thought I was coming to a panel where they were going to ask questions, not have to deliver a speech. But now that I've seen what Franz did, I'll just follow her act a little bit. Franz and I are often on the same speaking circuit at Queen's Park with the other party as well. So we know each other fairly well, and we may think of different ways to get to the end of the road, but I think at the end of the day, we're very similar in our compassion and our care for people. You were very gracious in giving me some of my titles that I've been given the privilege to have as a legislator. But really, frankly, I don't really care about the title. I've always just said to my party, I want to be part of healthcare regardless of what title you do or don't give me. The only thing that comes with the title, sometimes I get a little bit more shtick at the end of the day, so that's okay. We've covered a lot of ground today, and I want to start off by suggesting and being very honest with you, I'm not going to tell you what our party is going to do because, frankly, I don't have that platform in my hand. I haven't read it, so I'm not going to tell you anything that is PC party platform. What I will share more with you is where Bill Walker comes to life and where I see a lot of these things, and I'm going to try to cover a lot. It's always interesting when I hear the word revolution, and I'm not certain exactly which one of you said revolution, but as a politician, when you use a word like that, that can be taken off on a real tangent very quickly. What I will say to you, and I think it was you, Phil, that said we need to really start looking at how we approach healthcare and whether we want to use that word or not. I'm a big believer. I'm a recreation director originally, so I think of people and keeping them healthy, and we need to be a wellness society, not someone who is health and fixing you once you become ill. If you go back to dental care, very simplistically, again, Franz and I sat on a panel last week, and I'm a big believer because the Ontario Dental Association came and taught me when I was a brand new legislator that people, again, who are not given early detection, who are not given the treatment early, end up at a much more severe case. And you're spending 10, 15, 25 times to treat that person as if you gave them regular preventative medical checkups and the opportunity to have that. Brianne, you mentioned with mental health, and certainly the reality of having that early detection, the early awareness and that plan that you need. Probably 6 months ago, we were at the Life Sciences and Ontario Bioscience group, and a doctor came from the States, and he was refreshing because he again was talking, and a lot of it was centered on cancer. But we've again kind of get into the herd mentality where we just give everybody the same and hope for the best result for everyone. We're all different. We're all structured differently. What's going to work for you isn't going to necessarily work for me. So I think we have to get back to that individual medical awareness and how we're going to put the plan. But the key to all of those is absolutely early detection, early opportunity to be diagnosed and have the resources there. It's absolutely, I believe, a good thing for all of us that everyone now is at least talking about mental health. The government today came out with mental health money. We in our former platform made one of the largest commitments to mental health in a provincial history. So I think the good news there is everybody is finally acknowledging it, and we're treating it the same, or at least moving towards treating it the same as a physical ailment. And I think that's absolutely where we have to be because, again, it goes back to preventative and proactive, and I think we have to always be looking at those type of things. When I look at where we're going, so a few people said, you know, a legislator or a politician. I'm no different than any one of you. I'm a son who lost a mom to cancer. I'm a brother who lost a sister to cancer, and I'm a brother who has a sister who is a survivor of cancer. And every day what drives me is how do we get, whether it's my family or not, obviously, someone to be seen as quickly and as immediately as we possibly can and get them onto that path of health. Not fixing them, get them onto a path so that they know. And I believe it comes back to, again, individuals taking that care and responsibility. And all of the speakers today have talked about stepping up, and I took action, and I move forward. We all have to do that. Government is here as definitely a tool and a resource, and we pay taxes so that you have some of those. But I'm a big believer that, again, it comes back to individual responsibility for pushing that and asking those questions and having high expectations of what we have. But it has to be done in a very efficient manner. It has to be done with the mindset, how do we get them through the system as quickly as possible? I think Every one of you pay taxes. Every one of those dollars has to be, in my mind, looked at as an investment. Where do I put it, and what do I get with it out the other end? It's not an expenditure, it's an investment mentality, and it's always about outcomes. It's about, and we use terminology, I can't remember the gentleman's name who said patient-centered care, and we all talk patient-centered care, and there's dozens of reams of materials that talk about patient-centered care. But do we truly go back and actually live what we're talking? And we have to involve patients in every step of the way. I said earlier, I was a recreation director. One of my biggest learnings, I was a young guy, just come out of school, went back to my hometown, became the recreation, and my best friend was my biggest irritant because he complained about the shape of the ball diamond, the shape of the arena, the shape of the state of the ice, and I finally, it took me a little while, but I finally got him onto my committee. And he came in because he was a real sports guy, and he was an excellent sports guy, but he wasn't much into business or community. So I got him on my committee, and once he understood the ramifications of what he expected, he was a whole different person. And people would come up to me at a dance on a Saturday night and be in my face and giving me the blazes that he used to give me about the poor shape of the diamonds and the soccer pitches and whatever else. And he became my biggest defender because he understood what you actually had to do to fix some of these and how big the system is. And healthcare is so ginormous. I mean, it is absolutely the most critical thing to every single one of us. It's half of our provincial budget. It's certainly going to be more in the future with the baby boom demographic that's coming at us. All the more reason we have to be strategic. We have to think 3 steps down the road, but the whole thing comes back again to how we get people into the system as quickly as we can, we resource it properly, and we have the resources there when you need them in your time of need. One of the biggest things, I've been in not as long as Franz, I've only been a legislator for 6 years, so still the learning curve is pretty steep. But what I will say to you, the hardest thing as a legislator is when a family, particularly in my own riding, but obviously it doesn't matter where that's from, that's just who I have the most knowledge of, when they come in and they say, I need more care for my mom. I need more care for my daughter. I need those social and community services to truly provide for me. And you look at the government of the day, and I'm not being overly partisan, but they make decisions to borrow $25 billion for 2 years of hydro relief. But we don't put that money into cancer care. We don't put it into take-home drugs. We don't put it into things like long-term care where people, again, are in hospital beds because there's no facility. That's our most costly form of health care. Sending someone with mental health issues to the emergency department, our most costly form of health care. And whoever said, again, you spend 2 days in there and you still don't get looked at, or you go home. And having to actually lie and say, I'm going to take my life is the only way to get through doors. In my riding, we had someone just in the last 2 weeks, 6 days before they even got assessed. If you're at a point of crisis, you can't be told 6 days. And in some cases, it's much longer than that, which is horrendous. So again, in my way of thinking, it's always about, we have a pot of money. We've had the biggest revenues, record revenues in the 6 years I've been here, and we're still running deficits. We spend $1 billion a month on interest payments at the lowest historical interest rates we've ever had. What could we do for mental health, for cancer survivors, for people with depression and mental challenges? If we had $12 billion, $1 billion a month that's going into our economy, actually bringing new providers along. On that life sciences that I was talking about, we have procurement policies where we're either building technology or services in our own province, and our procurement policies actually prohibit us in Ontario from buying them. So Saskatchewan's buying it, the States is buying it, people across the world are buying it. We in Ontario can't even buy our own goods and services. In drugs, one of the most I think someone used the word appalling, and I'm going to use it in a similar manner. Finding out that the federal government does the actual testing and the screening and the approval of drugs, and Ontario in many cases goes and says, you have to actually study it for 2 additional years in Ontario before we'll provide it to our patients. So if you have a cousin in Saskatchewan who has the exact same thing, they're 2 years ahead of you on that whole treatment. How can we ever accept that we put it through 2 years because we can say, well, we're from Ontario and we deserve better? If that medication is working for your cousin, whether it be in Saskatchewan or BC, why in God's green earth would we ever think of putting you through 2 more years before you can? And the companies frankly say, if you weren't the biggest population base, we wouldn't even be talking to you because we can go sell it anywhere else. But again, many of those companies, to their credit, are from Ontario. They want Ontario to thrive, and they want it to come here. So when I hear certain things about certain companies, there are lots of companies. Someone talked about rare disease here. One of my colleagues just got an award for rare disease. Again, as a legislator, nothing worse than someone coming through your door saying, my daughter, my son, whomever it may be, needs this special drug. And we say, no, we can't provide that. There's only one thing that every one of us take in and out of this world, and that's our health care. And we all have the right, we all have the need, and we all have to be thinking about it big picture. How do we do things efficiently? How do we ensure that when there are drugs available, we find the way to get them into the hands of our people? Our practitioners are wonderful people across the spectrum, and we have all of that. Thank you very much. We have all of that at our disposal. What it is how do we maximize it? How do we use it? And how do we truly put, and I don't want it to be a cliche or slogan, people first. Because when I come to work every day, I gave up a pretty decent lifestyle to be that politician who works pretty long hours and is out on a Wednesday night here, because that's what I wanted to do. And it's all about making a better province for the people across our great province and across our great country. So thank you for being here. I look forward to trying to answer your questions and being part of the solution going forward. Thank you so much.
Thank you. Now we have time, first of all, for a couple of questions to our political party representatives, and then we're going to throw it open. Now would be a good time for Samantha. I'm looking for you. I'm not sure if she's in the room, but when she comes back, to ask the question that she asked earlier.
She's at the door, I think. I think she's at the door.
Yeah.
Samantha, do you want to ask your question?
Yeah. Do you need some time to look at it?
Just want to give you the chance to ask your questions and get an answer.
My question was, I just wanted to know, because of the state of the mental health system, what each of your parties is willing to do to change the state of what is going on.
Want me to go first?
Sure.
So, like I just said a few minutes ago, we are committed from the NDP to bring forward a Ministry of Mental Health and Addiction, to give mental health and addiction a home, to make a ministry accountable to make sure that we identified the best practices in mental health and addiction, that we make them available to all, so we don't have the issues that were shared with us, that I'm too sick, I'm too well, I live in that side of the street. Oh, you live in that Lynn area, you get it? You live in that Lynn area, you don't. This doesn't work. Plus, I would tell you that as a whole, we don't have a mental health and addiction system. It needs to be built almost from the ground up so that it is accessible, it is culturally accessible, so that people feel that this is for them, this will help them, it speaks their language, it connects with them, and it is effective in making sure that they get the care they need to deal with the mental health or addiction issue that or illness that they have. So for us, it starts by giving mental health and addiction a home, making it a priority, making sure that all of the providers and all of the agencies are accountable, are transparent, are based on outcomes, are using the best practice, and are providing good quality care.
Thank you. So I won't give a specific, as I said earlier, because I don't know that specific or have that. But I will suggest to you that in our previous platform, we had made that one of the key tenets of our platform on a plank. I think what we all have acknowledged is there is a huge deficiency, a huge gap, and what we need are the resources. We need people, again, to be able to get in very quickly, get assessed very quickly, and have a coordinated plan that they know there are resources that are going to be there. And that's going to take a little bit of time to train all of those needed resources who are specialists, who are the people that actually you want to be sitting across. And I, again, can't remember who said about the GPs. That's really not their bailiwick. They don't have the time to be experts in something like depression or mental health concerns, but we do need the resources that are there. So I think the key is to make it a priority, to ensure that you look at it, and again, take a look at best practices, look at anywhere who's doing it well. Sometimes it's going to be physical people, sometimes it's going to be that helpline, sometimes it's going to be medications and that care plan. But what you want, I think, is give me some help. When I reach out, I want someone to pick up and say, yes, what do I need to steer you in a direction, whether it be medications, whether it be resource. That initial assessment, in my mind, is so critical. My son has
struggled with some anxiety and very minor depression, and that was the biggest thing for him. Someone who actually would just say, I have the ability to help you, and I'm going to help you down that path, but you can't be waiting 6 months, 8 weeks, 10 months for somebody to even pick up the phone and say, what's your challenge today? That is absolutely unacceptable. So I think to your question, it's again being strategic, deploying the resources, and making sure there are enough resources across the province, and understanding the volume. I mean, again, I think one of the things that we've all perhaps learned is that because of that stigma, many people would not declare. They would not come out and put their hand up and say, I have. And we know the numbers are exponentially larger. But have we been training and providing the resources to ensure that you have enough of whatever the specialist would be? That's where we need to start and put our money where our mouth is and put some action. I don't want more study. I don't want more money spent on consultants designing and planning. I think we can do that internally. We have a huge Ministry of Health. We can take, as Franz says, perhaps hive a piece off, but there are enough people, I believe, within the Ministry of Health that you could take that and make it a specialized area of health. I don't really want to get into more ministers and more, because that's, again, money going to administration, not to front line. I want the money to resources that are going to be out there for people when they pick up the phone or they walk into that hospital or that clinic and say, I'm in trouble, I need help today, that it's there.
Thank you. I believe, Martine, you have a question?
Yes, I do. And today we saw the announcements from the Liberals about OHIP Plus, and the question is to each of you in representing your party, will your party extend the same support to expanding OHIP Plus to seniors, and would you do it sooner than August 2019 to help seniors?
So again, I'm just going to sound like a broken record. I'm from Wyerton, the groundhog capital of Canada, so it's a bit like Groundhog Day. But I really don't have the answer to that. What I will say to you is, again, I think everyone is aware of the concerns that are out there and that seniors in particular need. I'm going to just, if I can, though, use an example. So one of the things that was pledged today, and we've already had feedback from individuals about this, and it's about the child care. So someone's suggesting that everybody is going to get free child care, even though there could be a family of two very high net worth individuals, that you're actually now going to be that senior who's on a very fixed income, paying to support someone who frankly doesn't probably even need the help, but they've made it universal. So I don't like those types of policies. I don't like when we call something and don't put all the fact to it. The other point that they said in one of the announcements today was free drugs and dental and drugs for all seniors. The reality is it's a $400 cap. So that's not free, first and foremost. It's not covering everything that you want. So again, you have to look at the detail, and you really have to ask the question, when you're going to say free, what does that truly mean, and does that cover everything? Because most people, when you say free dental and free healthcare, that means everything. They're not saying, oh, I only get to buy these three things, and I go backwards with that. And let's not, again, get caught up in the whole word free. Nothing, as we're all taught by our parents, is free in this world. Somebody's paying the freight. So it's about making decisions. It's about making priorities. And I'm gonna reiterate, $25 billion for a 2-year hydro rebate. They're not fixing the hydro program. Your costs are going up in 2 years. And all of the people in this room that have spoken today about the challenges you've experienced, there's not $1 that $25 billion that they borrowed, which is going to cost, by the way, $43 to $93 billion to pay back. 43 to 93. What could that do for all of the causes we're talking about here today, whether we call it OHIP Plus or not? I want to, again, take those dollars and put it to the front line for programs and services wherever we can.
France?
I have no problem with covering children and youth 25 and under and giving them access to the formulary. Our seniors have had access to the formularies for quite some time. They have a copay. For low income, it's $2 per prescription. For people who are above the low income, it is $6 per prescription. A lot of pharmacy in my neck of the woods waive those $2 co-payments. So that the government wants to take that away and start paying for this, I'm not opposed. I'm sure it will help some seniors. But it leaves everybody between the age of 25 and 65 with absolutely zilch nothing. I have a problem with that. we've all heard from the people here that Medicare is not complete without pharmacare, that the 132 other countries that have Medicare also have some form of pharmacare. It has to be started someplace. It has to be for everyone, not just below 25, above 65. I want 0 to wherever it ends to be covered, and that's not what they're putting forward. So an NDP government would bring that forward. We would get it started here in Ontario, hopefully to go throughout Canada, all 10 provinces and 3 territories, as well as making sure that the formulary itself grows. But it has to start. It has to start now.
Yeah.
I should have mentioned earlier, Mr. Picard said again in Quebec with the private programs that are there and the insurance that you're requiring. Yeah, so I think again one of the concerns that I have sometimes when you come in and you only do the soundbite election ploy stuff is, are you really looking at how effective this is going to be? So if there are already people that are on programs that are being paid by either a private employer or the program they have, and we're going to say we're going to give everybody, well again, now you're taking money that could be going to other services and programs you can have, leave that private system in place and allow that to continue to go the way it's always been. People that are on particularly good pension programs and those type of things that have coverage, why would you ever take them out of that and pay it through the public purse? Because that's money, again, that's now not going to other causes that we could be there.
I'm ready for the next question from Anne-Marie. I thought you said Anne-Marie had a question.
Yes.
Okay, we can do that.
Hi, I spoke earlier. 28,000 patients are diagnosed, or 28,000 cases of lung cancer are diagnosed every year. In that time, people are waiting for very, very targeted drugs. We're finding more and more in the cancer sphere that cancers are not just bucket cancers like breast cancer or lung cancer. They're very, very specific, driven cancers or fusions that are treatable with targeted therapies or immunotherapies. My question to both of you, and I understand that our PC guest has not got a platform yet, but I ask both of you what you can do for patients that are waiting 1,700 days or more for public funding on our formulary when most lung cancer patients live 1 to 2 years.
So I think I covered it in my original talk. That access to care, that ability to have the drug and the treatment plan, and I'm very specific on the perspective I think you're bringing again. This ability to do the herd mentality and expect extraordinary results for people is just wrong. So we have to do that individual diagnosis. We have to understand what that special drug that you may need, as opposed to I may have a very similar form and don't need it, or it doesn't work as well. So I think we have to do that, but it's all about quick and timely access and getting you into the system. It's horrible. Particularly for that person who's being told you've got 6 months, but the drug's not coming for 9. I mean, how anybody can think that way and think that that's acceptable, particularly with all the other things that we have to deal with and what we see. And I'm not going to become overly partisan, but there is a lot of things that have happened in our system where money has been wasted, and those drugs could have been there. Again, I believe it's about choice, it's about priority, and I can't say my policy is, but I can tell you Bill Walker's policy will be at the table suggesting, along with many of my colleagues, saying this is about people. This is where we all came. We all came to Queen's Park or to Ottawa, I truly, sincerely believe, for the exact same reason. We want to make a difference in the world. We want to make the ability for people to have better lives. How we get there, we sometimes disagree on the path. But it's all about timely access and finding those ways. And again, working with the companies as well, because I think the other misnomer is that these are a lot of greedy corporations who don't. Most of them have very good programs, but they can't be expected to fund everything either. If they're not making money, they're not in business, they're not employing people, and the whole thing goes backwards. So we have to figure out a way to be able to work with the industry to be able to do that, but it's about priorities and timely, quick access and an individualized plan.
So I would say I agree with you that more and more cancer now has become a chronic disease, something that many cancer are treatable, and many cancer are now treated with take-home cancer drugs. So this is something that we are on the record. Our entire platform has not been rolled out. So the parts that I have shared with you are parts that we have rolled out. Stay tuned. There's 71 days between now and the next election. Who's counting? And the full platform of the NDP will be rolled out. But this is something that we have been vocal on. This is something that we have been studying. We have done our homework. You can expect something, but it will be for Andrea to share, not I.
Can I just say at this juncture that we have about 27, 28 minutes left this evening, and our intention was to throw the question and answer period open to everyone who has participated. There may be more questions for the representatives of the political parties, but I'd like to invite everyone to take their seats and to move into the more sort of open Q&A. So no one is excluded from that. We'll run the microphones around and we'll take any questions that come in through the Slido. I just love saying that. The Slido. Okay, so I think we have Chantal next, and we have a question here and a question from you, David. Yeah.
So I already asked this question, but I'm going to go ahead and say it again. This is just a discussion that I've had with plenty of other mothers who run into the same situation. I've been to the doctors for my 1-year-old, who you've all heard now, I think, a handful of times since 2018, and I have been prescribed at least 3 different prescriptions, all of which are my pediatrician has told me is covered under the new OHIP Plus program. Like, he tells me, take it, it's free. Out of the 3 prescriptions I have filled, only one of them was actually covered, and in terms of price, it was the cheapest of the 3. Mind you, they were not just simple prescriptions. They were for serious matters. One is a steroid for croup. My question to you is, what exactly does OHIP cover? OHIP Plus, because so far it seems that 90% of the prescriptions my daughter has been given have not been covered.
So I'm not sure to whom we should direct that question because we don't have a representative from the Liberal Party who is responsible for creating the OHIP Plus program. So I'm not sure who we can address the question to.
So maybe we can ask the two of our political colleagues who are here if they would do something to enhance that program that might alleviate this.
Yeah, or to say, what would you do that would help solve that issue? Yeah.
So last spring, the NDP announced that we were going to run in a platform that included pharmacare. Soon after, the Liberal government rolled out OHIP Plus. OHIP Plus is based on the traditional formulary that exists of 4,400 drugs. And they're really happy to repeat 4,400 drugs at least 400 times a day. But of those drugs, there's at least 4,000 that are not appropriate for children. And the drugs that are appropriate for children were never put on the formulary because most children were covered by their parents' plan. Therefore, there had never been a request for children because most of them are covered. So I come from Sudbury, I've already told you, highly unionized with what I would call bulletproof drug plans. So now a whole bunch of families that their kids are on complicated medication, they've never had an issue. Now they go to the pharmacy and the pharmacy says it's not covered. Oh, no worry, I have a good drug plan. No, the drug plan won't cover you. Now you have to go back to your family physician. In Nickel Belt, it's 6 weeks wait. 6 weeks later, you need your family physician who fill out papers for the Exceptional Access Program. The Exceptional Access Program is overloaded with demands right now, so it takes weeks to get an answer back. And once you get an answer back that says, no, we will not cover it, then you go back to where you were before on your parents' drug plan. This has been rushed out the door. It was not well prepared when it went out the door. The intentions are good to offer pharmacare is something that I support. The intentions are good. The rolling out of it has been problematic for many, many people, including you and including many others. They could have done a whole lot better had they been better prepared for it, but they were not. So a lot of families are going through a hard time right now. I'm working with a bunch of families whose kids are on Remicade because they have to buy it now. They buy it at $2,000 a vial, so it's like $6,000 every 3 weeks. But their drug plans, once I argue and fight it off with them, will only pay them the price that they usually pay, which is $1,200 a vial, which is, anyway, it is a huge mess. So it was good intention that could have been rolled out so much better.
And I'll just piggyback on what Franz is saying from the perspective of certainly that rollout. And the devil's in the details. Don't just read the headline when it says all are covered, when obviously in your case it's not covered. Nothing more reprehensible than telling you 6 weeks to go back to that doctor. What do you do in the 6 weeks? Most importantly, what's your 1-year-old doing for those 6 weeks? Now we're churning more time through the doctor's office who didn't need to even be involved in this after the first time. So those are the types of things I think, and I'm not certain who in the room said about efficiencies. Those are when I think of efficiencies. Making you go back through a process to go to a doctor to sign off on a form that you should have had 6 weeks ago is absolutely an efficiency that needs to be fixed. You have to ask the details. And I'm not certain what riding you're from, but what I would be telling you, what I tell people in my riding, if I hear of those, bring it to me and I'll take it to the health minister directly and ask what is going on. I'll ask for that definition, and it won't take 6 weeks for me to wait for you to be able to get an answer at least of what's going on.
Martine, where are we next? I have a question here in the front row.
Okay. I've got a microphone. My question is pretty specific, and it's to the two political representatives here tonight, and thank you for being here. Very much appreciate it. We heard from, I believe, Phil, who told us today that 1 out of 5 people suffer from depression. It's an epic disaster right now that takes its toll economically. When we look around this room right now, it means that 20% of us have some kind of a mental illness, and probably part of that mental illness is depression. We heard from this young woman right here, Brianne, who told us that there are 227 different kinds of depression. That her depression is not like my depression or his depression or your depression. And because of that, those kinds of depression need specific kinds of treatment. Unfortunately, for people like Brianne and almost everybody who is unemployed and doesn't have the privilege of being on a private drug plan, they can't access the innovative depression medications that they need in order to get well. So my question is, should an employment lottery actually be the deciding factor of your mental wellness? And what do you plan on doing about that in terms of that formulary and ensuring that people who don't have access to private drug plans have access to innovative medications that work for their depression?
Stay up front.
I'll get away from the speaker though, just in case. So kind of consistent with what I've said all night. Putting whatever that dollar value, I can tell you that the last time the platform was there, it was a 1.9 billion, the largest single provincial contribution at that time was going to be made. And it's making sure that we don't have to play a lottery. You want timely access. You want the resources. And one of the things that I certainly in my community, that's what I know best, obviously, Bruce Grey, Owen Sound, is we are significantly underqualified as far as resourcing. So again, there are those wait lists. There are those people going to the hospital and waiting 6 days just to get seen. That's unacceptable. So we need to ramp up those true human resources that are actually going to have the specialties and do that. But I think even going through, whether it's your clinic, your GP, wherever, is understanding that there is a clear path and we're not sending you back home. One of the families said to me, my son was in, again, this whole thing of I had to plead to say he was going to commit suicide to get him in. They kept him in for a day and a half. They sent him home with absolutely no plan when they took him out the door, when he left that hospital. There was no follow-up. They all went home. The mom was stressed, the dad was stressed, the sister was stressed, the son who was the patient was stressed, but none of them even knew where to turn. So again, there's such simple things I believe we can address very quickly to at least make sure we have a standardized care plan, a process, and we have the resources, whether it be on a regional basis or however we choose to do it. But the whole idea is, first of all, committing priority money to make sure that mental health is a priority in the healthcare system. It's at an equal footing as breaking your leg. I mean, you walk in and break your leg, you're in a half an hour and you're set and you're on your way home. Mental health, again, as we were saying earlier, I mean, that can be sometimes days, weeks, months before you get it. So that's the biggest piece. It shouldn't be, but we need to look at all of the opportunities. If there are plans out there, let's maximize them. Let's keep those going. And for those people that don't have plans, find a way to truly put a program in place that you have access in a timely manner.
Helping me now
Yes.
control the questions, because there are some
got a
coming
few.
in over the interweb.
Online, which I want to honor. I'm going to wrap up a couple of the questions that has come through. And I'm going to direct this to André Picard, because I think it's probably taking it to I want to say a greater level, but maybe a more comprehensive level than just Ontario. And we've heard a lot of common sense comments here tonight. Everybody has a lot of common sense, but what I'm not seeing is when we get to practicality, the common sense is no longer common anymore. So the question is, looking at, putting the patient at the center and looking at an outcome-based public policy system that rewards the stakeholders for better improvement and better outcomes of patients. How do we get there? I mean, Louise talked about a revolution. I mean, sign me up, Louise. I'll be your first soldier. But So the question is, like, what would be the linchpin or would be the catalyst to making the change happen? Because we talk a lot about it, but there's not a lot of action in doing it, and the common sense is out the door.
Well, that's an easy question. So I think I'll say first that the Canadian reality is we tend to go by evolution rather than revolution. So we do all these small measures. So the good news is lots of stuff is always happening in Canada. What's not happening is not happening quickly enough. So we have to learn to, I often say we've solved every healthcare problem 10 times in pilot projects, but we're not very good at spreading and scaling. So I think that's the first thing. Use the stuff we already know and do it. We could get a lot done very quickly. The second part is, if you want to talk more revolutionary, I think a big change that has to happen, that happens in other countries, is the money has to follow the patient, rather than, we tend to have block funding in Canada. So a hospital gets X millions of dollars, whether it has 10,000 patients or 20,000. And they're not rewarded for efficiency, they're not rewarded for good care, quite the opposite. You're punished because you draw more patients. So this notion, and again, we have some wonderful pilot projects on this that are successful, reward practitioners, institutions that do good work by drawing patients to them. Vote with our feet and with our illnesses, go to the people who care best, and the money should follow it. And we don't have that logic in our system now. That would be revolutionary, and it happens on a small scale, but not on a large scale. So that's just one example.
You need a
yes,
microphone.
Louise, you're part of the
But you need a
panelists. Louise,
microphone.
you're part of the panelists. You can answer.
You can after me. This is exactly what Porter and Teisberg are talking about in redefining healthcare. It's a value-based system that actually bundles the funding for each patient and allows the team, with the patient telling them what their value health outcome is, to determine where the money should be spent to get that outcome for that patient. So if it happens to be in health promotion and wellness programs, that's great. If it happens to be in drug coverage, that's fine. And it breaks down these silos that I was talking about earlier. And I really sincerely believe that it is revolutionary and it is the only way out. I would also just like to say that 125 multi-stakeholders met a week and a half ago at Rotman School of Business, not necessarily deemed a revolutionary institution, I don't think, to talk about this very issue and how to make this a reality in Canada. And we welcome all of you. We're early adopters. Join the early adopters, and let's really start telling everybody who we elect and who we pay, by the way, that we want them to move in this direction. And if you're right, they probably won't do it as fast as we want, but we need to know that, as I say, I look at every policy and I say, is it getting me closer to value-based healthcare, farther away from value-based healthcare, or is it agnostic? And I make my decisions about those policies, whoever policies they are, based on the answer to that question.
Okay, I'm going to let Phil
follow up on that for just
follow
2
up and then
seconds.
we'll go. Yeah.
First of all, Bill, when you think about people with mental health issues and the fracture analogy, just think about the fact that someone who has a mental health issue needs a crutch, and that's a medication in most instances. And when someone has a fracture and is fixed up in a hospital, what happens? They're given a crutch. Or perhaps they're given a wheelchair, and then as it heals, the wheelchair goes to the crutch. So just keep the physical issues in mind when you think about mental health issues. The other thing, and I agree completely with Andre as far as funds are given to the patient to follow. One of the big problems for mental health issues is that a lot of our treatments are community-based. Our community-based groups are not properly funded by the healthcare system. I was significantly helped by peer support groups, and they're always on their last legs. They're always begging for money, except if peer support's funded through a hospital, and then they're gold-plated. But the reality is that we really need to pay attention to community-based organizations. NGOs, if provincially get a little bit of money, they get nowhere near the kind of funding they should get if they were considered part of the healthcare system.
I'm just going to jump in on top of you to say that one of the things I've really noticed through this conversation, and because I'm also a patient advocate, is that very often the mental health issues, the anxiety, the depression, go part and parcel with other disease conditions. So they are basically syndemics, and we have these concurrent epidemics of these issues, and the healthcare system really needs to do a much, much better job of looking at how we deal with these things concurrently, because a lot of the conversation has been actually rather siloed in terms of all of that. Can you pass the mic to Pam, who's really keen to make a...
Just make sure that
yes,
when you're talking about
I've
a heart...
got your name wrong. Jones, sorry.
Just when you're
but to
talking
make
about a
comment.
heart, that's all
Yeah.
people are talking about.
Yeah.
If you talk about the person, you talk about the heart, the mind, the body.
Yes. Okay, Joan, and then David, and then I want to see if there's anybody else who hasn't had the chance to ask a question to do so.
Yes,
So
just to remind
quickly,
everybody,
please.
I'm from the rare disease community, and in the rare disease community, we don't use the word revolution, we use the word transformation. Yes, we want a transformation in our healthcare, right from start to finish. The whole thing needs to be fixed. But one of the things we talked a lot about tonight was the National Pharmacare Program, and yet we've talked about it, and yet we've talked against it, and I don't think we really understood that we talked against it, because a lot of times now what we're looking at, even in cancer care, is more individualized treatment. The reality of individualized treatment is the same way as in rare disease communities. It is individualized because our patients, sometimes a drug that works for one patient doesn't work for the next patient because the diseases are so complex. The reality of it is, if a national pharmacare program is as bureaucratic as the existing programs that we've got, we will not, our doctors, our specialists will not be allowed to give the medicines that our patients need based on their best assessment of what their healthcare needs are, not what the bureaucrats have decided or what the clinical trials have decided, because clinical trials are, again, in rare disease communities, they are so small and they represent such a small proportion of patients. So how, and I'm not specific, I know nobody has an answer to that. The reality of it is when we get an answer to that, we will have transformed our healthcare system. Thank you.
Thanks, Joan.
Okay, I'm going to pass it over to David.
Thank you. This is a bit of a follow-up on your question, Anne-Marie, and Mr. Walker started to describe this. I have a type of cancer. It's called multiple myeloma. It's incurable. It has a median survival time of about 5 years. I've got many friends who have passed away. There are some new treatments available that are life-saving that have been approved by Health Canada, but it's taking a long time for approval by the province. And part of the problem is the approval process is very complex. It involves an organization called CADITH, another organization called the Pan-Canadian Pharmaceutical Alliance, another organization called the Canadian Association of Provincial Cancer Agencies. These agencies, by the way, are all driven by the provinces. And then there's the review within the province itself. So a question for Mr. Walker and Madame Jelina and anybody else. What would you do to alleviate some of the red tape and streamline this approval process so we can have access to these treatments?
I'm going to pass it over to
I would say you sort of summarize what we have, and you've actually left out a few in the committee to evaluate drugs, and it's even worse than what he's actually described. All that being said, I think some of the solutions came clear tonight, and I fully agree with them, is that why don't we have patient advocate at strategic place in the system? Why don't we review this entire, I mean, it was supposed to be that once we started the Pan-Canadian, that was supposed to help speed things up so that every province would not have. I haven't seen any neck-breaking speed happening out of that process yet, and I hope it changes, but I'm not sure. Bring some patient along. Make sure that, I think it was Zell who mentioned it, that we are doing all of this for the patient. They should be the voice that we listen to. They should be the one who are the drivers and the motivators, because it doesn't matter how good we think a provider is doing. If they're not meeting your expectation, if it's not what you wanted, then it's all for none. And I agree with you, the process is very cumbersome. It is very opaque. I'm the health critic. I have tried really, really hard to look into this. I can't even name the people that are on those committees. This is how secret this thing is. The only thing I see is I see their report at the end, and lately all of the reports that I have seen all come out the same. Yes, the drug is effective. It should be added to the formulary if you can negotiate a better price. This is a death sentence, because that means there is no process in place to negotiate a better price. Therefore, the new drugs that is effective, that has proven to save lives, will sit there forever on end till the drug company starts to do the round at Queen's Park and tries to make noise and all of this. And really, the drug companies should not have to come to me. We should have a program in place that looks at the value for the patient through the eyes of the patient and meets the patient's expectation, and we would be way further ahead than where we are now.
So I definitely think that, Franz, you're 100% right with the patient advocate being at the table, but I just think it doesn't need to be nearly as cumbersome as it is. We need to be starting to look at outcomes. We need to be starting to put pressure back on whoever the government of the day is, of what have you got done in this file in the last 6 months, because there's no reason someone like you, David, should even have to be having this conversation. If there's a drug already approved by Canada and it's in another province, I can't accept, frankly, whoever's government it would be, my own included, that we're going to actually ever say to you, no, we're just going to have to go through this and figure it out later. There has to be outcomes. We have to get our whole mindset, transformational, whatever you want to use, but it's got to be about outcomes, and it has to be, it's just insanity that we would actually think that your brother, your cousin, someone who you don't even know in Alberta is taking the drug that's going to give you those 5 years, and you're being told that it's going to take 2 or 3 more years in Ontario. We just cannot accept that as people, and we can do, I think, very simplified. There are people within the bureaucracy that can drive those. The minister can have way more, I believe, although I've never been privileged to be in government or cabinet minister, which I probably never will be, but I believe you need that leadership. You need people who are going to stand there and say, this will get solved, and I think it can be an agreement across the provinces. There's no reason, I think, if you have the federal minister of health and all the provincial ministers of health, that those people in those rooms can't figure out a process that streamlines that and makes it absolutely as effective, and it should just be a no-brainer. If it's approved by Canada, then it should be within a month available in whatever province it's there.
All right. We're going to Zal, who I'm pleased to say that a patient advocate is getting the last word or asking the last question.
Oh,
no pressure.
such a prominent position. You know, I am a patient advocate, but I'm not. I'm a patient activist, and I think that's different. I have Crohn's disease, yes, but I don't advocate for Crohn's patients. I'm an activist for the patient experience. And, you know, this conversation sort of echoes some of what I talked about and what I'm fearful of, and that is that the individual disease state silos are going to be pitted against one or against the other. To hear today that, you know, the proposition of a ministry dedicated to mental health, well, while promising, I would suggest is actually reverse discrimination. We have clearly, you know, in the country, we have, what, 175,000 cases of cancer diagnosed every year, not including 75 or 80,000, you know, cases of non-melanoma skin disease, skin cancers. We have, you know, but you know, there's all kinds of diseases. So what are we going to say to those people? What are we going to say, for instance, and here I'm going to advocate for a particular disease group, one that you can't ignore. And what are you going to say when you've dedicated so many resources to 1 out of 5, but there's 3 million people with type 2 diabetes in this country, and we are constantly bombarded with messages around the issue of a tsunami of diabetes. And how are we going to manage that? And how are you going to communicate with these people? And how are you going to justify allocating resources to mental health or to cancer and denying 3 million people in this country access to the kind of treatment they need, the right treatment, the right physicians at the right time, at the right place? How do you do that? And how are you going to manage that? So what I'm saying, and what I ask really is, fundamentally, what principles are you really dedicated to? Is your driving principle being elected, or is your driving principle reducing suffering and improving the human experience? That is really the essential core question that an activist for human experience will ask, not an advocate for a particular disease state.
So did that require an answer? It's
that's up to you.
rhetorical.
That's
It's
up to-
rhetorical.
that's up to
Or as a friend of mine says at moments like that, when the moderator says, "Is there a question?" My friend says, "Yeah, I want to know if you agree with me." All right. I think we are.
We just have one question that I
okay.
want to answer because it's very simple. Is this session being recorded and will be available tomorrow? The answer is yes. We'll provide the link to the recording so you can have access to it and listen to it again and share it obviously with your community because I think this is, you know, a very important conversation, discourse that needs to happen and continue. Thank you.
Thank you, Martine. And thank you, everyone who came in person this evening or joined us by live stream. We really, really hope that you enjoyed the presentations, and we also thank you for taking time to submit your questions. So if you'd like to continue the conversation as part of a collective effort to craft a series of messages for political candidates in the upcoming provincial election, you are more than welcome to sign the contact sheets out this door and on the back table, and you will be contacted by a member of the health policy group. Also, we would invite you to please help us spread the word about our next town hall, which will take place on April 5th in Ottawa. It's available, or registration is available through the Eventbrite website. And again, just a reminder, and I don't think we had any really unanswered questions. Well, I did. It's about the meaning of life, so that's not going to happen. But you're welcome to spend a few more minutes talking here, although I remind everyone that we really have to vacate the building by 9:30. So again, just on behalf of the hosts, thanks to our sponsors, our presenters, and most of all to you for your active participation in tonight's town hall. Louise, did you want to make a closing remark?
I really would just, I want to thank you all for coming and staying till the end. And I personally had a great time. I don't know about the rest of you, but I love a party, and this is a party, and now maybe we have the after party. I just want to make a comment to Zal's comment, and it is absolutely, we should never allow anybody to divide and conquer anybody with medical conditions, because if one of us is not safe, none of us is safe. So, amen, and let's remember that. There's obviously some more egregious activities in some areas than other, but the reality is we need to work together. We need to message together. We need to applaud the successes of each of the groups and all of the groups wherever and whenever that opportunity arises, and never, never let them see it as a competition, because having a disease ain't no competition. If it is, I'd rather lose. So thank you very much.